to indicate where we are on the agenda as we go through it. Unfortunately, we are back online today. And that's because of the industrial action. Many of our executives, particularly clinical executives, need the flexibility to be able to attend or support frontline services if necessary. So we took the difficult decision to move the board meeting online to facilitate that. For the same reason, if we have to, we will take a break in the board meeting. But again, we'll indicate that very clearly as we go through the meeting. So I'm going to start with apologies and welcomes. We've got a few apologies today for different reasons. Nicola Matthews, independent member, Pat Price, independent member, Judith Vincent, Health Professional Forum co-chair, Richard Thomas, Director of Communications and Engagement, and Gareth Howells, Nursing Director. Yes, I think that's it. In terms of, we also though have a few welcomes to the board, and a goodbye. The goodbye is to Keith Reid, our Director of Public Health, who has, of course, led us through in his public health role through the terrible COVID period, and was a key health system leader throughout that period, leading our Gold Command and providing invaluable guidance, support and direction to the system. He leaves us with such a legacy, though, in the form of our population health strategy, which has received great acclaim from a number of different sources. I also think that he's certainly changed my thinking, and I think he's changed the thinking around this board about what we can do, and importantly, how we must change culture and behaviours to deliver that population health strategy. So we're very grateful for all you've done, Keith. We wish you all the best in your secondment with Welsh Government, and we will look forward to continuing a close relationship with you in that role. But I did want to thank you for your contribution to this board over your period as Director of Public Health. We also have a welcome to Sarah Jenkins, who is our Interim Director for Workforce and Organisational Development. Sarah was the Deputy Director of Organisational Development and has kindly agreed to take on the interim role for a period of 6 to 9 months, pending an outside recruitment process. Similarly, a welcome to Hazel Powell, who is our Interim Director of Nursing and will be supporting Gareth as he leaves towards his retirement, and again, we will be going out for external appointment process for the substantive role, but it's great to have you around the board table, Hazel. And finally, she's not actually here, but I'm delighted to say that we have a shadower, a mentee. Steve has a mentee through the Welsh Government shadowing scheme, a lady called Moisha Merry. She's unfortunately got COVID, so unable to join us today, but she will be attending committee meetings and board meetings as part of that shadowing scheme, and I think she will bring a great deal to the board, as well as hopefully learning a lot from us for future application processes for herself. As always, today I want to maximise our time for discussion, so executives can be assured that our board has read the papers diligently and digested them as well. So please can we keep introductions to an absolute minimum so we can really focus on substantive discussions today. It's a big agenda, of course, because we have the annual plan and other aspects. So with no further ado, I shall enter into the board process itself. So first of all, do we have any declarations of interest for today's agenda? No, excellent. So first of all, we'll move to our patient story. Board members will be aware we always start with a patient story which grounds us. Today's patient story is entitled PTSD, My Story with the NHS. And I'm delighted to welcome Liz Brimacombe to support us in that, but I think Hazel is going to introduce us. Thank you, Hazel.
Thank you, Chair. So likewise, really pleased to welcome Liz, who's a principal psychologist who's been involved in this work and will help support with any questions after we hear the story. So just to give a brief background and context, this lady had an admission to Morriston Hospital, which resulted in her requiring support in intensive care. Her experience has led to her having post-traumatic stress disorder, and in telling her story, we will hear her explain how this has impacted on her accessing healthcare subsequently, and the difference that individual clinicians have made along that journey, both good and bad. The patient story is a really good example of "you said we did," as we used her experiences to consider what we could do differently. And we developed an alert system to support this lady and others when they're accessing our healthcare. So the alert enables staff to access patient-centred information about their PTSD and what will help them manage appointments and or admissions to hospital. So I'll let the story go from here.
It took me 7 hours to build up the courage to get there. By this point, I was in such pain, I had to go. My sister phoned ahead to say that I needed to come in and that I had PTSD. They were very sympathetic with how I was triaged. They told me to go and wait in the car and that they would phone call me. They were wonderful. She constantly assured me she was telling me what she was doing. She spoke to me as an equal. She didn't speak down to me just because I had mental health issues. She told me that she would do her best to get me seen quickly. She assured me that it was clean. She opened the window. She said, "Look, I'm opening the window." I think it was the respect, the dignity, the information. I built up trust with her that she was capable of doing her job. But although it was very difficult and it had opened up memories and I'd had a flashback, it was a positive experience going forward for the next one. The next time that I had to go back, I was spoken to as if I was being a naughty school child. That's how I felt. She was standing up, I was sitting down. She'd given a diagnosis. She didn't want me to ask her questions. She said, "Here's the exercises." That I can't do them. You will get on with them, and keep trying. You will get on with them. Off you go. And I was shaking. I was shaking at this point. I became quite insular. I started using my wristbands. I started using the techniques. It opened up memories that I had of racing through my mind, other experiences of the similar nature. It was the tone, her manner, the abrupt responses that she was giving, and it was the body language that she had evaluated. She'd done her job. Move on. By the time I got into the guide, I didn't want to go back to a hospital environment again. So my positive experience now turned into a negative experience, and I had to go back to the hospital the next day. And it took a lot of talking to me from my family to go the next day. So the next day I went to see the consultant. He read my notes. He was, again, so understanding. He knew that I had PTSD. He took the time to explain to me what was happening, to show me everything on the scan. He said that so far I had been treated as though it was a low-grade sprain, but in fact it was clear that it was a significant damage to 2 of my ligaments, and I was put into a boot and told to stay off my foot. It was a real positive experience. So I have to go back on the 30th, and I'm looking forward to seeing him again. But unfortunately, I went to physiotherapy yesterday, and it was really dire. It was awful for me to be having to tell him to please pull up his mask at the end of the session. I could see the top of his lips. He was saying to me, "Look at me, look at me." And I said to my mum, I couldn't look at him because all I kept thinking about was that mask and him working with all these people in a hospital setting with COVID rife as it is, with all my anxieties. And I'm trying so hard to manage my anxiety because his mask is low down and I just didn't feel safe. So as well as asking me if I had cancer, he was going, PD, what is that? What is that? Oh, that's post-traumatic. there was no awareness then, okay, this person has got mental health issues. Okay, I need to be mindful of that. It was pretty dire. And I just didn't feel safe.
What a powerful story. Hazel.
Thank you, Chair. Yes, I think it's a really good example of how we've taken the learning from patient experience and developed our system, which is, again, people opt into it. So people who've got PTSD can now work with our clinical staff to develop the alert. So we have really person-centred and individualised approaches for people. But Liz is here and has been the person down the middle of this. So probably hand over to Liz to answer any questions.
Down on mute. Thank you. Liz, is there anything you'd like to say first in relation to the story or more widely for board members? This is your sort of platform.
Thank you, and it's lovely to be able to speak. So there are a lot of patients who come to us with post-traumatic stress symptoms, not always as serious as disorder or having dealt with medical adversity. Sometimes it is just simply the nature of the experience is nothing to do with staff, and it's just the nature of the difficulty they experience. What happens typically with post-traumatic stress problems is anything that's very similar to the experience, it sets off a very difficult reaction. So the idea was to let the medical staff know that there's somebody who's going to have who's likely to have difficulties with triggers, as they're called in the trade, if you like. Particularly hospital environments are very difficult for people to come back to. This is really classic for intensive care, but it's across the board. And so the alert system on the Welsh Clinical Portal is where doctors would normally see that maybe somebody has an allergy or there's some medical information. So that's already a system that's well working. So what we've added is the alert saying that somebody has PTSD or post-traumatic stress syndrome or symptoms. And then there's a very brief note saying what particular things might help that patient. So it's incredibly personal, and it is personal because some people need quiet and to be in a calmer space or have somebody speak slowly. Other people need a window opening. They need somebody to hold their hand. So it's very individual what helps. And as part of the service we're delivering, they have often have little cards which help them calm and help them reorientate to things that help them when they're very activated by the hospital environment. So I hope that's enough of a summary to give somebody a feel for it.
Thank you very much. It's it's good to see the alert system being used for personalised care, isn't it? I mean, obviously the allergy information as well, but that's really positive development, and entirely in line with our aspiration, our vision to become a high quality organisation providing personalised care to individuals. So thank you for that. I've got two hands here now. I've got Nuria and then Rena.
Thank you for the story. That was a really powerful story, I thought. But and I do take into account the alert system and what you're doing there. But it's more, my question is more around just having that trauma-informed care on the round, which is really, really, really important, which this raises questions around. So I was wondering whether you could tell us more about how that works in practice, you know, when people, for example, experience ACEs, etc.
So you're meaning how it works when a patient comes into the service?
Yes.
So, well, typically, and actually that's really a broad question, to be fair. Mostly when people you can be traumatized by relational historical trauma, which is more to do with your life story and your experiences outside of hospital. And then you can have a medical trauma. So our particular interest has been medical trauma, but we're broadening out the understanding of how we are when we're traumatized by things when we're younger. So we are actually doing a lot of training led by the Traumatic Stress Wales initiatives to bring trauma-informed care to every branch of not just medicine, but across our society. So there's going to be levels of training depending on the amount of contact you might have with somebody who has a trauma experience. But I think we need to broaden it to adversity. Most people as well have adverse experiences, whether they've had childhood, so that's adverse experiences as children can leave you very vulnerable to health and mental health issues later. So in fact, in a medical setting, you are more likely to see somebody who's had difficult experiences. So we are trying to, Alison Gorman, who leads as the trauma lead for the trust, is trying to work her way around lots of different teams and work arenas within their health board to deliver trauma-informed care information. I'm part of that team. Does that kind of cover it, Muriel? Maybe it's a
Yes, no, thanks, Liz. That's really, really, really helpful. It's just thinking about how our systems work and our response, because it's a great step in the right direction, but there's clearly more that we need to do as a health board, and I think that's why I opened up the question. I do take into account that it was a very big question to ask, but it's touching on the adversity and what we're doing around that, which is really helpful. Thank you, Liz.
Yeah, you're welcome.
Thank you, Nuria. Rena.
Yeah, my question was similar, Liz, in that it obviously struck me from the story that perhaps some of the staff didn't understand PTSD and maybe hadn't had any training or awareness in this and how to recognise it and what their response ought to have been. And in a way, therefore, and not that I'm saying they're blameless, but the bottom line is, in a sense, with lack of awareness, you don't necessarily, in a busy situation, know what you should be doing. So I think that was my sort of query, is how do we ensure that our staff are in a position to know what to do, given the alert that they possibly can now see?
Well, it's a very good question, Rena. Thank you. And the alert does give some information just briefly about what's helpful, just bullet points. So there is that is empowering as much as anything, because trauma for many people is a very daunting subject and people don't know how to react or what to say. So an education program is vital. And I would like to see this kind of information as mandatory training, like we've done with dementia, so that everybody gets even a brief understanding of what happens when we're traumatized and how we can react. And actually what I think the helpful thing is to be able to pause and look at your own reaction when somebody's behaving in a way that you're not expecting, perhaps. Traumatized people can react in ways that evoke something in us, and we lose our patience or we become defensive. So it's a broad educational program, not just about what trauma is, but about what happens to us when we're with people who aren't responding typically. Is that helpful?
Yeah. Thank you. Thank you very much indeed, Liz. That was a very thoughtful start to the board, and we will need to reflect. I mean, we do quite a bit of training around trauma awareness for staff well-being, don't we? Which is presumably quite helpful, but perhaps want to reflect on wider training needs as we go forward. Thank you. Okay, that's a good start. I'm going to move on then now to the main business of the board. Liz, you're more than welcome to stay, but you may have better things to do.
Well, not better, just different. But thank you so much for letting me speak, and I hope you have a good meeting. Thank you. Bye-bye.
Thank you. Thanks very much indeed. So we now move to the formal part of the agenda. We've got minutes of the 31st of January. First of all, for accuracy, are there any comments on accuracy? I'm not seeing any hands. No. Okay, so we're happy to accept those as an accurate record. Yep, I'll take no hands as assent. Receive and consider any matters arising not otherwise on the agenda. Have we missed anything out of those minutes? Nope, good. And then we've got the action log. I think everybody, the action, we've either got plans or they're complete. The open actions are all in progress. Frailty strategy in June, update on continuous flow in May, and primary care and mental health state priorities in May. We content with those and content with the closed actions? Fab. Okay, that's great. So we now move to
Emma,
yes.
Emma, I'm very
Yes,
sorry for the
Tom.
late notice. I attended the January board meeting, but I'm not in the minutes. So just
Oh, thank you.
like that.
Thank you very much, Tom.
Well, thank you.
Great. If we can just make that change. Sorry, did I miss your hand? I'm out of practice with running Zoom meetings. Okay, so we're now moving to the chair report, which is a written report and provides an update on the chair recruitment. I'm delighted to announce that Jan Williams will be joining the Health Board as the substantive chair from the 1st of June 2024. It is the first step in a number of steps that the board needs to take to ensure that we have a really substantive board, and I'm delighted that there will be no gap between my leaving and Jan joining. Jan and I are already in discussion and conversation, and I will of course make sure that she is as well prepared as I can help her to be to take over this wonderful organisation on the 1st of June. My report also comments on external relationships. The site visit, it gives a bit of an update on the independent member programme of site visits, which I think is helpful, plus the template that will be used, the board committee update, and then chair's actions. The only thing I'd add to that was Richard and I made a visit yesterday to Morriston to hear about the plans to improve the layout and space around our emergency department. A key part of this work will be to provide and develop a frailty hub where we can provide dedicated and holistic care for our frail elderly patients rather than putting them through the trauma, frankly, of the emergency care pathway. And I think that will be a really positive development, both in terms of the focus that the ED will be able to provide for other patients, but also the ability for us to be able to provide the holistic wraparound care for the elderly that come into our system. So I think that will be a very, very positive development and is a key part of our annual plan this year. We would anticipate it having a major impact both on the unscheduled care performance figures, for which of course we're in TI, but more importantly, the quality of care for our patients, both the frail elderly and those that need to come through the more traditional ED route. It will also provide a significant improvement in the quality of the job satisfaction for staff at the front door, which currently is a very tricky situation, as we know. I'm very happy to take any questions on it, but I would like to ask the board to agree for us to sign up to the corporate parenting charter by the 8th of April, as I've set out in my brief. I can see nods, which I'm assuming is around the corporate parenting charter, and I'm not seeing any hands for questions. So I think we can agree to sign up to the corporate parenting charter, and we will move on to Richard and the Chief Executive's report. Thank you.
Diolch, Emma. Thanks, Emma. Bore da, everybody. The written report, as much as the chair's report, is there for board members to read through. If I may, though, I'd like to draw out a few key points and to go through those in sequence through the report. It's fair to say that the first quarter of 2024 has presented the Health Board with a number of challenges alongside the operational pressures, which have been particularly acute in recent weeks. But in spite of these pressures, the Health Board has remained focused on delivering our 10-year vision for improving our health services for the people that we serve, and that clearly involves putting patients at the centre of everything that we do, driving up quality and efficiency throughout our organisation. And in the coming months now, we'll continue that focus on the One Bay Way approach, which helps us on our journey to becoming that high quality organisation. And that's really important, because what we want to do is deliver the best possible healthcare for our patients, while at the same time providing our staff with an experience that makes people proud to work for Swansea Bay University Health Board. And we believe that this is the only way that we can address some of the root causes of some of the pressures we're facing today. Just to say then, in terms of what that means, so it means that our top priorities mean that we need to make improvements in the areas of greatest challenge and greatest risk. But it's important to say that these are also the areas of greatest opportunity, because in resolving these issues will improve the quality and effectiveness of the care that we provide and will result in better outcomes for patients. Our focus in this regard is on reducing length of stay in our hospitals, and not only doing so by shortening the length of stay when people come to hospital, but actually a core part of this, as Emma has alluded to, in terms of our frailty strategy, will actually be to look for alternatives to hospital admission for frail, often older people, because we recognise that hospital isn't the best place for the care or the treatment that they need. And that will need a seamless interaction between primary care, secondary care, between our specialist geriatricians and our general practitioners and our services in the community, to make sure that we're able to provide, wherever possible, care closer to home rather than in hospitals. We're determined to continue to improve our delivery of outpatient services, to improve our performance when it comes to cancer and to planned care, and to develop a quality-focused approach for the benefit of our patients, our staff, and also to help us live within our financial means. We recognise that getting things right first time, reducing infections and preventing rather than curing, will help us deliver improved patient outcomes in a more timely way, and that in turn will enable us to make the best possible use of every pound that we spend. I would just like to highlight a couple of positives. We've eradicated waits of over 52 weeks for outpatient appointments and sustained that now for 4 months, just over 4 months. So we're seeing our patients more quickly. That's leading to earlier diagnoses and a better idea of how to prioritise treatment for those who need it, and for peace of mind for those who don't. We're also making big inroads into our 104-week waits for treatment, achieving 96.6% against the ministerial target of 97% at the end of December. And the provisional position for 104 weeks at the end of February is ahead of the trajectory that we'd submitted to Welsh Government. As we've discussed at board before, all health boards were informed by Welsh Government in January of the revised escalation status. Swansea Bay had previously been in enhanced monitoring for planned care, cancer, finance, planning, maternity and maternity and neonatal services. And the result of the latest tripartite meeting, the escalated status for the health board was increased to targeted intervention for performance and outcomes, while it remained in enhanced monitoring for planning, finance and maternity and neonatal services. We have had a series of meetings with the Welsh Government in relation to these various areas to agree the type and the frequency of the reporting required, the measurements, the metrics by which then we'll be working towards de-escalation. It's really important to say that the areas of concern that are highlighted by that escalated status to target intervention are the same areas of concern to the health board, and are those principal areas of focus for us within our plan for 2024-2025. On industrial action, we're currently in our third round of industrial action by junior doctors. As Emma alluded, Emma and I visited Morrison yesterday and had the opportunity to meet some of our frontline staff, which included some of our physicians and surgeons, our consultants who are acting as junior doctors have been over the last 3 days and the last day today. They've done an absolutely magnificent job in making sure that our services have remained safe. They are tired. They're undertaking jobs that they would last have done probably 20 plus years ago, but they're certainly determined in their efforts to make sure that we're able to maintain those core services for the most critically unwell patients. It's fair to say as well that a huge amount of work has gone on behind the scenes by our managers in our services to arrange rotas, to make sure that provisions are in place to make sure of the safety of those services, and also by colleagues amongst our executive team who've had those conversations at a national level, making sure that we're aligned across all health boards in terms of our approach. It's important also to recognise that while we've maintained safe core services during the period of industrial action, we're very conscious that that has had an impact on patients who are scheduled to have planned care with us, whether that's outpatient appointments or elective surgery, which has meant we've needed to defer those treatments. I'm going to leave board members to have a look through some of the metrics which are contained in the report around unscheduled care, cancer, planned care, because there'll be an opportunity to discuss those in more detail. On infections, COVID, flu and measles, there's been a slight increase in the rise of COVID infection and admission rates to hospital, largely amongst the elderly and amongst children. It's one important point to draw out in that section of the report is the concern over measles outbreaks and clusters in England, and a cluster in Cardiff. We're really determined to work to address immunisation uptake in school-aged children and in health and social care workers. It's particularly important for children. Although measles might be seen as a traditional childhood disease, it can have devastating effects on children who are infected that persist throughout their lives, and so protection against measles is absolutely crucial. On Tata Steel, we're also very conscious that of the job losses that are likely to arise over the next period of 4 to 9 months, about 2,000 jobs at Tata Steel, which is obviously a key employer in our health board area. In response, the UK government, jointly with Tata Steel and the Welsh government, has established a transition board to manage some of the wider implications of the job losses and the closure, the temporary closure of the plant. And the people skills and business transition subgroup has been established, which has health board representation, and the report details what the health board's role in that will be. We're very aware not only of the impact on our local population, but we're also aware of the impact on staff. We have many members of staff who have family members who are employees at Tata, and are deeply concerned about the impact on them and their families. So we're encouraging staff to support each other through this difficult time, and we're also directing staff where appropriate to our wellbeing services. On quality is clearly a key focus. Just to draw out two things in there. Firstly, the external review of maternity services. The Health Board's commissioned an external review, and Margaret Bowron-Casey, who's chairing the oversight panel, released a statement earlier this month indicating next steps in terms of finalising the scope of the terms of reference and seeking views on the further draft. And Margaret Bowen will be giving the next update after the Easter break. On the Welsh Fertility Institute, board members will be familiar with the concerns that had previously been received about the ability of the service to satisfy the regulator, the HFEA. But I'm very pleased to say that one of our challenges in that area was to identify an identified post of person responsible for the HFEA, and pleased to say that we've had 5 senior members of staff come forward to undertake the training that's necessary, and have already had 3 of those members of staff who've completed the training, with the other 2 due to complete shortly. We're undertaking a deep dive review of the service to better understand the constraints and the risks, and that'll mean we'll have a baseline assessment to have ongoing conversations about options and recommendations to put the service on a more sustainable footing. More broadly, in terms of infection prevention and control, we have had some infection-related challenges, particularly an outbreak of Clostridium difficile at Morriston Hospital. While we've had cases at Morriston Hospital historically, it's been some time since we've actually had an outbreak of C. diff. That certainly is a manifestation of some of the unscheduled care pressures and the pressures on beds in the system. But colleagues are leading on that with our medical directors and nurse director to address those issues, and as part of a wider conversation happening about refurbishment of our estate on site and developing a ward refurbishment programme. I'll turn then to finances. We'll have a conversation about the annual plan on later in this meeting. A couple of things to draw out on that. We will deliver on the deficit target set by Welsh Government at the end of this year, and are now in the process of submitting our financial plan and annual plan for 2024-25. We fully recognise the significant resource that was made available to the NHS by Welsh Government and how that was negotiated across different departments, and we're working hard to understand the options and choices we have to move towards financial sustainability. We will be taking a deficit into the next year, and to address that deficit, it's likely to involve some challenges around the services, challenging decisions around the services we provide, and the need to ensure that we've got strong controls in place alongside that additional funding to deliver sustainable services, and also to address those areas of concern that are outlined that are represented by our targeted intervention in those in planned care and scheduled care, and cancer in particular. It's really important, though, to take that in context. While the challenge is there, as I highlighted at the top of the report, we have got a 10-year vision. We've also got some fantastic clinical teams who've shown a real appetite for change and transformation. And I think while there is a challenge in balancing delivery and the money, actually there's a real opportunity for us as a health board to push on now during the next 12 months and really accelerate the plans that we've already got in place to transform our services for the better of our patients. And then finally in the report, Chair, just to highlight the conversations that have happened over the last period of weeks about the Emergency Medical Retrieval and Transfer Service. The Emergency Ambulances Services Committee, ESC, met in March regarding the recommendations for reconfiguration of the Emergency Medical Retrieval and Transfer Service, EMERTS. This is following the phase 3 of engagement that was concluded in February, and the update on that is that the Joint Committee has agreed that further work is required in relation to recommendation 4 in that report, and also some representations that SLICE have made. And the outcome of that will be that there'll be a special health board meeting held on the 10th of April to consider those final recommendations to determine what the next steps will be for that service change proposal. And I will end there, Emma. I'm sorry I've taken a lot of time on that, but I felt those issues are worthwhile drawing out, and I'm happy to take any questions.
No, thank you very much, Richard. It's very helpful, I think, to have that sort of state of the nation at the start of the meeting. Okay, any questions for Richard? I mean, clearly a number of the things he's referring to come up later on in the agenda as well. But as I say, it's good to have that overview. No, okay, so I think we will therefore move on and onto the risk register, which is Hazel.
Thank you, Chair. So the board last received the risk register in the November meeting. So this is the February version of the risk register. It contains 32 risks, 20 of which are scores at or above the Health Board's risk appetite and threshold. 2 of these risks are scored 25, which is unscheduled care and access to cancer services. In terms of a further update, no new risks have been added to the February risk register. 1 risk is reduced in score, which relates to midwifery staffing levels, and 8 risks have either been closed or de-escalated down to service group level or a corporate director level. Generally then, in terms of risk management training, this continues. Pleased to report that level 2 training has now become a mandatory element of the manager's pathway, which is really helping managers take forward risk management. And we continue to do workshops as well for service groups. The updates in terms of the risks are contained within Appendix 1 and within the report, and happy to take questions.
Thank you very much, Hazel. I can see a question already. Nuria.
Thank you, Hazel. Just to update the board, really, we scrutinised the risk register in our latest audit committee meeting, and it was really pleasing to see the movement in relation to midwifery and the inclusion of the population health risk. We think that these actually reflect the discussions that we've been having as a health board. We alerted the executives of the need to review our controls in relation to partnership working, and we were really pleased to see that those discussions were already happening in the Population Health Committee and that the risk at the moment is being assessed and underway. My question, I think, to the board is around risk appetite. We reviewed the risk appetite back in November 2022, whilst in recovery, and given where we are in terms of escalation status and finances, I wonder if it may be prudent for us to consider reviewing the risk appetite again in the near future.
Thank you, Nuria. I think that's a really good question, actually, and I can see Hazel nodding as well. Hazel, do you want to comment?
Yeah, absolutely, Nuria. We are reviewing our developing a risk management strategy. So as part of that process, that should be ready to bring to the July board. And I think prior to that, we'll be reviewing the risk appetite as well and including in that report back to the board then.
Sorry, couldn't get myself off mute. That's good. Does that answer your? Yeah, I think that's good. So we'll make sure that that goes in the action log. And any other questions on the risk register? I just had one on the fetal screening, which is at 20 and has been there a while. Do we have a view? I know this relates to we're screening at 4-week intervals rather than 3-week intervals, which is the target. But do we have a target date for when we'll get back to this the target score for this risk? And I can see Hazel's already put her hand up.
Chair, I can give some information on that. So we introduced midwifery sonographers, and we have been able to generate increased capacity as predicted. So radiology confirmed that they are able to accommodate that increased programme. So we are able to scan on a 3-weekly basis, but we don't currently have the resource to review the scans appropriately. So this is being picked up via our maternity improvement and assurance board, who I've asked to come back with a project plan with timelines and also to consider further mitigation whilst if there's any implementation that needs to take place. So that's where we are with that, but I should be able to come back with a timeline at the next board, if that's helpful, or in between. I can get that back to you.
Thank you. I think that would be good. I think it would be useful to have that and certainly updated on the risk register next time it comes. Excellent. Thank you, Hazel. Any other comments on the risk register? No, in that case, we will move on to the next item, which I assume is the BAF. It is indeed the Board Assurance Framework. So back to you, Hazel.
Thank you, Chair. So the Board Assurance Framework was last presented to the board in November. So this has been updated and scrutinised and challenged by the Audit Committee as part of processes. We do use the Board Assurance Framework in terms of developing and setting work programmes for the committees of the board and used to inform internal audit and Audit Wales's work programmes in terms of their audits they undertake. At the time of reporting, we're still working through and meeting just to gain some updates in relation to the BAF focus on population health needs, and this will be taken forward now in April. We've also developed a user guide, which I think has been really helpful for people, and just wanted to thank really Audit Committee members in particular for the challenge and scrutinise of this important document, which has really helped to evolve. And I think that's all I wanted to say, Chair, and happy to take questions.
Thank you. Thanks very much, Hazel. I can see a couple of hands up. So first of all, Hazel Powell. No, previous item. Okay, fine. Nuria.
Again, as Hazel has mentioned, we discussed this in the latest Audit Committee, and we really welcomed the improvements made to the BAF, and in particular the user guide. We particularly welcomed the changes that we made in response to the scrutiny, so we wanted to thank the executives for doing that. It is a developing document, and it is important to note the reasonable assurance that was provided by our internal auditors. There is a challenge remaining outside of the population health, which is looking at other sources of assurance, for example, drawing on in relation to estates, things like fire safety, rescue inspections, etc. And food agency, there's so many inspections that go on, and maybe it is drawing further on those assurances. But as I say, we're really pleased with the way that this is developing and recognises that it is an ever-evolving document.
Thank you, Nuria. And the Audit Committee has clearly been a great support in the development of the BAF. So thank you to you as chair and the audit committee. Yeah, I think there's always a need for more external assurance as much as we can get. That is what gives us the greatest level of assurance. Any other questions on the board assurance framework? Yes, Jean.
Yes, thank you, Chair. It was just an observation, really, because I think this document, even in the short time that I've been with the board, has helped really inform and hone in to the areas that we are having the most concern around. And for instance, one of the urgent and emergency care moving in the wrong direction, it's very visible. So from my perspective as a board member, I just wanted to thank everyone for the work that's been done on this, because I think this document is really comprehensive. From one concern I had was on the population health, which has just been addressed. So I won't continue to ask that question. Thank you very much.
Thank you, Jean. Rena.
Yeah, in some ways it links to Jean's point. I do think this is a really important document, and in some ways we are using it now, and that we will continue to embed it into our agenda planning for the committees, because it clearly very easily identifies the areas we should be focusing on. So I'm very keen on it. Thank you.
No, thank you, Rena. And it is, if we reflect back a few years ago, we didn't have that clarity. And indeed, when you looked at it, it felt like a different document to what was actually happening. So I think Jean's point about the fact that it is consistent with what we see on the ground, with what we pick up, and with what we're worried about. That gives us that means it's doing exactly what it needs to do, which is providing the board with assurance. Good. Okay. Let's move on then. Jean, is that another hand, or is that from before? No, from before. Okay. Right. So we now move on to the key issues reports from first of all Quality and Safety Committee. Over to you, Steve.
Yeah. Thank you, Chair. So these reports cover two meetings. The one held on January the 23rd and one held on February the 27th. It's quite busy meetings. Just try and take some themes. The reports are there for your digestion. There was a nice patient story on January the 23rd, which brought something to my attention, at least, which hadn't occurred to me before. It's titled Denture Daisy, and it's a focus a new focus that we have on oral health among our patients, and it especially affects frail elderly people who can't brush their teeth properly or clean their dentures properly. And it causes some distress for patients, because they can't understand, for example, why their loved ones recoil from embracing them, for example. And we've got a colleague now who is focused 100% of her time on making sure that the people in the wards across the whole estate know how to support the upkeep of oral health. So that was a poignant patient story. We had an update report from primary and community care, and the committee was pleased to see that the quality and safety governance structures at that level are being developed and established. We've got the board has seen the structures at the top of the organisation, but these have to be developed all from the bottom up, and the primary and community care have done a particularly good job in getting their new structures in place. In the February meeting, in both meetings actually, there was a focus on infection prevention and control, and in particular, as the chief executive referred to, the problems we have around two particular areas, Staph aureus and C. difficile. And in fact, it's a bit more nuanced than just we have an issue with infection prevention and control. Some areas of our estate have very good records. It's just a few wards, and mainly in Morriston, where we have particular problems. And we are actually quite good on most of the healthcare acquired infections. It's just those two that are particularly challenging. And the committee was pleased to see that a multi-agency support approach had been applied to the the C. difficile problem, which has resulted in a serious outbreak at Morriston in the last month or so. We started to focus on the targeted intervention issues around quality and safety, and in particular, we were looking at ambulance handovers, which we're aware of have been a big problem for us. The chair referred to a meeting yesterday she had, or a visit yesterday she had at the emergency department in Morriston. The committee members have also visited the emergency department in Morriston, and I've done so independently with the vice chair of the Welsh Ambulance Service, and it was great to see that the plans around the frailty hub that the chair referred to earlier are being developed, and WAST colleagues, both the vice chair of WAST, but also some of the operational colleagues that she brought with her, are also very impressed with the plans we've got there to set up the frailty hub and make that front door much more focused on, where the patient should go to, because one of the patient stories we had, and that was in the February meeting, was around a patient that had been for many hours in the emergency room at Morriston, and the sort of impression that they had, and the treatment that they felt they were getting, and the waiting that they had to do in uncomfortable situations and circumstances. We've all been there to see that. So it is good to see that there is a focus on this area from certainly the management down at Morriston, but also from colleagues on this committee and on the board more generally. And I think those were the only highlights I wanted to draw out. So happy to take questions.
Thank you, Steve. Are there any questions for Steve? Darren?
It's not a question, Chair, just a point in terms of the environment at Morriston Hospital, and recognising that we've got a variety of qualities of environment, and particularly in the ward areas. Now that the service group director has been able to free up decant space for us, we can start a programme of not to revolutionary ward refresh, but actually improving the environments to help with the infection control agenda. And we'll work that through in the coming financial year and the years which follow through our internal discretionary plans. So there's positive news in terms of that environment, which has been a stubborn issue to fix.
Thank you, Darren. Just there's quite a lot of background noise on your audio stream. Okay, referring to what you started with the dementia, sorry, the Daisy Dental. Having read your update, I was very pleased to see when I went round yesterday in the orthopaedic ward I visited, that was very prominent. So that is clearly something that we are taking forward with gusto, which is great to hear. Richard.
Yeah, just to add to that, I think it's a really good case in point, isn't it? So not only is it nice to have a clean mouth and to feel that you've got a clean mouth and it's more pleasant. Actually, for those patients, particularly patients with fracture neck of femur, it's a really important part of the care that we provide, because we know that patients, when they break their hip, need quite high dose painkillers to address the pain that makes them drowsy. And patients who don't have clean mouths or who don't have clean teeth actually are at a much higher risk of getting pneumonia in hospital because they aspirate because of the painkillers. So it's a great example of a personal intervention that's not only more pleasant for the patient, but actually has a direct impact on outcomes. And it's how we tie in members of staff who maybe aren't providing the high end of care and doing the surgery and replacing hips, but how our healthcare support workers in particular have a really important role to play in making sure that patients have good outcomes from the treatment they receive with us, even when that treatment involves complicated surgery. Actually, it's the simple things that we do for people also have a positive benefit.
Yeah, no, excellent. Thank you. Okay, thank you very much, Steve. There is clearly a very wide agenda on the quality and safety, as it should be, and it's a helpful report to have aboard. I'm now going to move to Rena to provide the key issues report from Performance and Finance Committee, please.
Thanks, Chair. Again, you've got reports from 2 committees here, starting with January, and it's reflected into February, really. We were looking at, obviously, the financial position in year. And I'm pleased to say that in this week's meeting on Tuesday, we received good assurance that we are going to deliver on our landing plan, which is our 17 million control total. So that was very reassuring, given that we weren't so certain earlier on in the early part of this year. Then if I move to the other things that were on the agenda, in terms of the January meeting, obviously we had a long discussion about unscheduled care, cancer, and particularly on workforce and the sickness, which I know is going to be an area that we're going to be looking at in the year to come. Because obviously we do have one of the highest percentage of sickness figures within Wales, is my understanding. So that's been referred to workforce, and I know that's going to be given some focus. We then had a look at prescribing and prescribing costs in particular, which have been bigger than budget allowed for. However, what was interesting in that report was the fact that we were informed that they would have been so much higher if our prescribing colleagues hadn't been doing the work they have been doing to try and, reduce the cost of the high cost drugs and move people onto lower cost drugs, which do the same thing. We had a look at NEC of FEMA. We've talked about that, and I think particularly there, what is obvious is we need to have more focus on ring fencing the right beds within Morriston so that people can get into the right wards and get surgery quickly. And then, interesting, we looked at immunisation rates. That has come out of a discussion we'd had, that they had fallen away slightly, and given the measles outbreak, we wanted to look at performance across the board in terms of immunisation rates. So that's interesting. Then moving on to February's committee, as I said, I referred to the finance already. Theatre efficiency came up under performance, and we are receiving a deep dive report on theatre efficiency next time round. We looked at the annual plan, the Q3 performance. The Additional Learning Needs Act was an interesting report because this is a new legislation that has come in and placed new responsibilities on the Health Board. And in a way, there is some difficulty here because we don't really fully understand the demands that are likely to arise, and it has particular implications for our speech and language therapy. So we need to work with our local authority colleagues to work out how this is going to work going forward. But I think there is particular concern about the particular budget implications of the loss of a SLA, which previously existed with the local authorities. And I think that's probably the run through. Thank you.
Thank you very much, Rena. Any questions for Rena? Clearly the financial outlook for next year will be brought in a later paper, but it is very good news about delivering our control total for this year, which will be the 4th year on the trot that we have done what we said we would do. And I would much prefer it was at 0, but it's also very important that we do what we say we're going to do and that we are realistic in our plans. Okay, I know that the items you've mentioned are also going to come up in later papers as well, Rena, so I can't see any questions and I'm going to therefore move on. This is the report on the external review of maternity services, which is to Hazel, both Hazels, in fact.
If I start off, Chair. So the board announced in December an external review into maternity and neonatal services. The review will consider 3 areas, each led by relevant independent experts, which relate to clinical outcomes, patient and staff experience, and leadership and governance. The independent review will involve a comprehensive engagement process with service users who will have the opportunity to input and provide details of their own experience. The patient and staff voice is really critically important to all of this, and we will be taking that forward. The chair to the oversight panel is coming to the end of appointing members to the oversight panel, and in April a further update will be provided, and we're expecting that as she's been evolving the terms of reference, there will be a 21-day public feedback process where people can comment, and then the oversight panel will further consider the feedback in terms of the terms of reference before signing them off and the review formally commencing. So that's all I wanted to say, Chair.
Thank you very much, Hazel. Any questions on that? No. I mean, clearly it will be very good when the review starts. It will be better for the service and better for the patients who are want to provide their feedback into it. But it is really important that we get these things right before we start off on them. And I think I'm very grateful to the chair of the oversight panel for the work she's done to date. I think we will receive regular updates from her, which I will bring to board. So thank you very much indeed, Hazel. Okay, we now move to the finance report. Darren.
My audio issues resolved, Chair. I've had some messages say it was poor last time. Not, thank you.
Yeah, that's much better. Yeah.
Okay, I'll lean in as well. So I'll take the paper as read. Just want to pick up revenue capital and the payment policy. Report is month 11 update. And in month 11, we overspent in the month by just over £1 million. 2 million of that was related to the costs of industrial action. That's 2 episodes of industrial actions which had worked through the payroll by that point, mitigated by £1 million of internal activities which were expected. So that took us to an overspend position of just over £41 million after 11 months. And clearly we're tracking a target control total of 17 million. Across that 24 million gap, we've needed to release some balance sheet opportunities, which the audit committee kindly signed off with Audit Wales present just a week or so ago, which gives us confidence in a significant proportion of the 24 million gap. And then through some of the things we've been tracking around our contractual performance, some money back from WISC and the drive we've had to manage cost as part of some of the choices we made just over a quarter ago. We are reporting a high degree of confidence of hitting the target control total, clearly subject to the ongoing audit processes, which we respect at this time of the year. From a capital perspective, I just wanted to draw out some of the key numbers really. Our discretionary capital is about 11 million, but the way the course of the year works, our capital limit has increased to nearly 60 million. And that's through a huge range of things like substation improvements, imaging, replacement. So whilst we have a small and modest internal resource to just deal with day-to-day things, we've attracted over £50 million worth of national money as part of our agenda, which is something that evolves over the course of every year, and I wouldn't want the board to miss the way the scale of that has developed. We were reporting some risk in the receipt of income when this report was drafted. Again, delighted to report that we will balance the capital resource limit as well this year, as well as hit the target control total for revenue. My other target then is to pay invoices, or 95% of invoices within 30 days. A little bit of trouble with this in previous years, just been sub the 95% level. We'll achieve that as well this year, notwithstanding anything tricky in the next couple of days. And the last point I wanted to raise was around risk. We report 2 risks through this paper. One is around the revenue position and delivery. One is around capital. We reduced capital last month. I would have reduced the revenue one after the audit committee, but the paper was already submitted. So those risks are a little out of date. With the support of the Performance and Finance Committee, we'll refresh those risks for the new financial year. Cognizant of the discussion on the financial plan will follow, Chair. That's all I wanted to say. Thank you. I'm happy to take questions.
Thank you, Darren. Any questions for Darren? No, I would just like to pay tribute to Darren for bringing the control total in on this financial year. That has not been an easy process and has involved a great deal of effort, both by the entire organisation, but also by Darren and his team. So I think it is, as I say, it's not, we would prefer to be in balance, no question about that. But the next best thing is to deliver what we said we would deliver, which is what we've done. So thank you for that, Darren. If there are no further questions, we're very quiet today. I'm going to move to the next item, which is the Ministerial Performance Report. I think that's still with you, Darren, is it?
Yes, it is. Thank you, Chair. There's a wealth of information and papers here. I'll skim through. The board this year requested a paper which correlated performance, risk, finance and delivery of plan, and that's what this does. This is the 3rd one of these this year. So the paper is deliberately set to the end of the 3rd quarter, but clearly the board will be more aware of the updates received more recently in terms of performance. So I thought I'd just pick up some of those things as I go through. I'm taking the paper as read. So page 4 of the report shows our emergency department 4-hour performance. That was 74% in December. We've had a 77% in the middle, but we're looking at about 74% for March as well, given there's only a couple of days left. On the 12-hour waits in the emergency department, there were 990 in December. That dropped to 959 in January. That's around about 1,200 again now. And if I turn to page 5, and these are ambulance hours lost due to delay in handover, that was 3,700 in December. And whilst we dropped to 3,300 in February, it's likely to be around 3,600, 3,700 this month. I picked those out specifically because those are directly related, the last two in particular, to the reason why we're in targeted intervention. And we know and understand that, and the graphs bear that out in terms of our stated trajectory and actual performance. Cancers over the page on page 6, with 51% of patients treated within target time in December. That was 48% in January. We know we have to improve that. And the way we will improve that is by reducing our backlog. The backlog chart beneath on page 6 shows that when this report was drafted, we had 302 patients waiting over 63 days. This week that reduced to 194. It was 600. So we've made substantial inroads into the backlog. That's better than profile. And that's largely now across urology, lower GI and gynecology is the 3 main tumour sites. All tumour site weights are reducing as a result of our focus on early outpatient access and trying as hard as we can to get a decision to treat on the pathways by day 31, so thereby giving 31 days for treatment. So positive news. Until that backlog reduces further, we will continue to see slightly lower percentages than we planned, and then once the backlog's resolved, those percentages will recover. Page 7 is the 104-week waits. If you look back to December 22, we had 8,000 people waiting over 2 years. At time of writing this, December was 2,900, February 2,175. And notwithstanding the loss of some activity this week due to industrial action, we are confident that we'll get to the 1,842 we stated, which will be around 90%, if not better. I know the team are working on that at the moment, so I wouldn't want to be definitive on that figure. There's lots of work that goes into that, but it's in the right zone, and that probably will be better than that. Outpatient waits over the page, we've achieved, as the Chief Executive said, no patients waiting over 52 weeks in October. That's continued, and we continue to depress that wait, which is clearly helpful for patients to get an assessment and a diagnostic. And endoscopy waits at the bottom of page 8, 3,500 in December, 3,003 now. But our overall diagnostic waits have reduced from 5,006 in December to 3,008. We've seen a 31% improvement in diagnostic access just in the last 2 to 3 months, which is incredibly impressive. The CAMS charts are set on page 9. There's been a continuation of good performance here from December. There's been a blip on the mental assessments, which is the top chart, just in February due to some staff absence, but I know the team are bouncing back from that. We continue to be 100% on the interventions, and in terms of the care and treatment plans over the page, we're also 96% there, so substantial improvement in CAMS performance and access. We took a briefing on neurodevelopmental disorders at the Performance Finance Committee this week. There's more to do there. The team is being supported to do that, and there's lots of work going on to look at pathways and workforce models. Risks we've discussed earlier, they're set on page 11 for completeness, and the financial components of the plan which drove those improvements are listed in the table across pages 11 and 12. There's a significant appendix that colleagues in Narissa's team have pulled together to show the broader implementation of the plan for Q3, and the usual performance report, which has been scrutinised by Performance and Finance Committee, is also appended for the board's information. Chair, I'll stop there.
Thank you, Darren. So to a certain extent, the forward plans for the ministerial targets and others are in the next item, which is the annual report. So this is in a sense a bit of a back look, but do we have any? We do have a question. Rena.
It's not really a question, Chair. It's just I was going to say that all of the areas within this report are areas that are on the work programme for performance and finance, and obviously we are looking them at on a quarterly basis. But I particularly wanted to reference the neurodevelopment disorders, that we were very concerned that this is not moving in the right direction. And we have asked for a recovery plan to come forward to an early committee in the new year, because it is such an important area in terms of children care particularly. And we had a very encouraging report from the speech and language therapy at Tuesday's meeting. And I think what that did show is that by transforming the pathways, within the service, they'd made real inroads into the waiting list and into the waiting list for therapy, waiting list for assessments and waiting list for therapies. And it seems to me that what we need to be looking at here is that kind of transformation, because it is very dire and has been for a long time in terms of the performance. So I just wanted to alert members to the fact that it is on our radar and we are looking at it. Thanks.
Thank you very much, Rena. Narissa, are you going to come back in on that? Or is it a different point? You're on mute.
Yeah, I just want to come on the NDD. I was tied up with something else, so my apologies, Rena. I wasn't there on Tuesday. It's the NDD service is quite a complex one, and it's a problem across the whole of Wales. So actually it's a problem across the whole of the UK. So it's a massive issue in terms of the way that the service is delivered. And essentially what we do is children start to display kind of behavioural issues in school, and therefore they're referred in for assessment into a service. The waiting times are significant, and in the intervening period they're sitting on a waiting list without necessarily dealing with the underlying issues that are being manifested within schools and at home. So the discussions we've started to have within the RPB group is to do precisely what you're suggesting, which is to look at a pathway provision, because not all children will need assessment. So the main reasons previously were for legal reasons, really, to be able to access services. Well, the law changed about 18 months ago on that, so we really don't need to have an assessment to be able to access services. And the CAM services, where people have already, or kids are beginning to display emotional problems, have a really good in-reach service, a school's in-reach service, which picks up kids. There's no mental health kind of connotations. They're really kind of workers that are working within schools to address the issues in school, to help children who are displaying behavioural issues in an educational system. And we need to look at NDD in the same way, so that we're intervening at a much earlier stage, if at all, and so that they don't end up onto an assessment platform, because we don't do a great deal. We assess, and then if there's a diagnosis, there'll be a diagnosis of whether there's actually mental health issues, in which case the children move into mental health services and are picked up by the CAM service, or they may have ADHD, in which case there is a lifelong medication program to manage that until they maybe grow out of it. A lot of children do, or the others, we just have a report that says this is the needs of the service, and that's the end, and that's all the waiting list for that assessment process is doing that, really. So I think we've got to look at this in a different way, because some children will absolutely need an assessment because they're complex and really need to go through that multidisciplinary team, but others won't, and there are much better interventions earlier on in the pathway, integrating into schools to be able to manage this. So that's what we will be putting into a recovery plan. I think it's Aneurin Bevan did a kind of review of how much it would cost to do the backlog clearance on the assessment pathways for NDD at the moment. I think it's something like £12 million. So I don't think that money is best spent on kind of clearing backlogs on waiting lists. We're better to really have a bit more of a dynamic plan. So that would be the basis of the recovery plan that we'll be bringing forward to the next performance and finance committee.
Thank you, Narissa. That's very helpful. And it's good to hear that this is being done as part of the Regional Partnership Board, rather than us trying to just march on alone, because this is absolutely a multi-agency issue. And so that's helpful. Any other questions on the ministerial priorities report? As I say, it is history, really, isn't it? Anne-Louise. You're at a strange angle, Anne-Louise.
So is Jean. We've been turned upside down twice now in this meeting, and it just seems to happen. So I'll have to, after I've asked this question, I'll have to come out and completely and switched on again. I don't know why it's just Jean and I who are being tipped upside down, but there we are. So if you can concentrate It was something that Nerissa said, and I just wonder whether the local education authority has something to do with it, because my understanding is that one of the issues that schools have when they identify problems such as this, there's a huge waiting time in the education authority for them to come along. It's not, for example, the parent who starts this, initiates it, it's the local education authority. And I wondered if that's part of the issue that we have, that there are huge waits when the first intimation of the problem begins and is identified by school.
There will definitely be an element to that, and the way that we're tackling it with CAMHS, where there's identified mental health kind of kind of diagnosed kind of issues is to have an in-reach service that picks them up. So you work with the education, they in-reach into the school, so they don't wait at all. They're picked up by teachers, and then you've got an in-reach worker that's working into the school environment. So you're not waiting at all. There's no link then to a further referral. And we need to do the same with NDD, because the two things are getting badged together, and they're quite different, actually. So so I agree that, but you can only do that through multi-agency working. So, which is why we have to tackle this through the RPB mechanisms, and we've strengthened the governance around that. So Kerry Gimlett now is the deputy chair of that RPB programme, and she's the service group director that leads this. Michelle Mason-Gorn is a regular attendee on the work forum. It's only just kicked off this year, so it's a fairly new part of the RPB structure, but it's key that we have a much more interagency approach to this, and just take the waiting times out. Rena's absolutely right. What we've done on speech and language therapy is really superb, transformational work that changes the way you deliver the services, reduces the amount of wait, and actually makes it a cheaper service to run in once you've cleared your backlog. So and I think with NDD we could be making far better use of money by really getting the intervention at the right spot.
Thanks.
Thank you. Thanks both. Andrula.
I just wanted to pick up on that point around the multi-agency and the importance of that, because it's really a very challenging and quite anxious time for parents in that space, but particularly in that limbo of not having a diagnosis and not knowing what the next step is. And it is really key that we start empowering all of the services within the community, that's general practice, all of the community services and education, where that normal environment of the child lies around, because every bit of support in that time is really important, and that connectivity and that information sharing is absolutely key, that those parents don't feel that they're on their own whilst they're waiting. So I think there is more than just sorting out an appointment here. There is that whole connectivity and that wraparound support, which very often can be, clusters can be a great vehicle for that, because they have those links and that connectivity already exists. But we must make sure that everybody's on board when we are making those changes, because a breakdown of that can be quite difficult then for parents to maneuver, and we need to be absolutely key to make it very seamless for them.
Thank you. Thanks very much, Andrula. Pat very kindly sent me some comments because she was unable to make today. And I thought one of them was, I will raise it's on the performance report rather than the ministerial priorities. And that's why I think it's worth raising, because in the prioritization of the things that we know we've got to do through TI and ministerial priorities, there are other areas that we mustn't forget. And the one I'm particularly interested in is the follow-up appointments, waiting over 100% beyond target. I know it was brought up in Performance and Finance Committee, but could I just ask you, Deb, to give us a bit of an update on that? Now you've come off mute, but we can't hear you.
Can you hear me now?
Yeah.
Right, okay. Change of settings. Zoom is throwing gremlins at us, I think, this morning. Yeah, so the follow-up not booked has been within RT2 reporting for a while, and it's obviously now it's part of our touted intervention measures that we've got to address as well. We've had some success in managing the long waits within that area, but not as much as other health boards have. So we know going forward into 24-25, we've got to now shift some of the focus of our performance elements into that waiting list. A lot of the patients waiting on that waiting list are artificial. We know that it's just system issues, and the system does weird and wonderful things with patients who are not on what we call an active waiting list. It's a follow-up one, and sometimes they see different clinicians as part of that pathway, and it creates duplicate pathways as well. So the first thing we're going to be doing, Chair, is going through digitally to see if we can extrapolate those that are actually actual patients waiting in a follow-up cycle and those that are not. Once we've done that, we're then going to be looking at implementing what we call a see-on symptom and a patient-initiated follow-up pathways, which are where patients are not clinically needed to come back into follow-up cycle, but the clinicians just are not ready to discharge them, or the patients sometimes want to stay in the cycle. And then we move them into a different pathway that they contact us when they need to be seen. And that can be valid for a period of 6 or 12 months. So our focus now, particularly in Q1, is to work through what is the real patients waiting and which ones that are not, move what we can with consultation with the clinicians, because it's got to be done at a specialty level, because there's obviously different conditions with each specialty that need to be managed differently. So I think we've not done as much as we could have in this space. We have to acknowledge that, and I think this gives us that extra drive and focus in the first 6 months of next year to get that and get a grip on that. We're also going to engage with other health boards to see where they've had more success than we have, so that we can learn from where other health boards have had those quick wins, so we duplicate, and then we can focus on where our problem areas are.
Thank you, Deb. Okay, any other questions on that? No, in which case we will move to the annual plan for 24-25. This is a very substantive document. I think it's a great document, actually, Narissa, and one of the things that I am particularly pleased to see is that we're putting some really hard messages and some really challenging trajectories within the context of our strategic direction of travel, which is really important. So with that little preamble, I'll hand over to you.
Okay, thanks, Emma. Yeah, there's a huge amount of work that goes into this plan. This plan was kicked off in September last year. So and there's a lot of engagement that my team do with the organisation in order to generate the output that you see in front of you. So there's a significant effort that goes into the development of this, and a lot of hard work in terms of making sure that the organisation's engaged. What we've been trying to do, and what I've got in the document is really that there's a triangular document which on page 41, I think it is, it's in the planning approach, and that gives us the kind of golden thread as to how this document pulls together. So we've got the organisational vision, so that's all about transforming the way that we deliver the services. It's about empowering our staff to deliver good care. It's about the One Bay way. So that is broadly the way that we want to see our organisation move forward. We did a lot of work as a board, informally and formally, through the autumn and into the early part of the calendar year around strategic objectives, and those are documented within the plan, and we debated what those mean and how we see those working. We've translated those into system vision. So we've done a lot of work in engagement with the service groups around what those system visions should look like, and how they translate those strategic objectives into something a little more kind of operational. And then there's a big part of this document around the GMOs, and there's a huge piece of work that goes on in the generation of those. And there's a criteria that's outlined in there in terms of feasibility and deliverability against which we've gone through those GMOs, and there's a rigor to that as a process. And then what I'm trying to do, and Deb and I are working hard on this, is making sure that the GMOs relate back to things like the outcomes from targeted interventions, so that the things that are in those GMOs link back to then the delivery plans that we will need to put in place to deliver the ministerial targets and the targeted intervention undertaken. So that is basically how the plan works, and I think that's really important. But the driver from this is to transform the way that we deliver services, and to use the population health strategy that Keith and his team have pulled together to make sure that it isn't just Keith's population strategy, that it's a population strategy that underpins absolutely everything we do, and that we transform services in a way that moves and shifts the way the care is delivered to people. The vast majority of the population will access their healthcare through their GP, and so it is far better to try and to start to wrap around services around primary care and support primary care to keep people away from hospital settings. So it isn't just shifting services, although there's a huge degree of that. It's actually developing an approach that enables primary care to hold on to patients, so that we don't refer into more secondary care services which are inappropriate. And we've talked a little bit about the pathways on neurodevelopmental. I could talk about every single pathway in the same kind of way, where actually we end up with patients at the wrong end of the system. So we're doing a lot of work around emotional well-being, we're doing work on diabetes, to try and get as much delivered into a primary care setting and the broader community services, so that people don't need to access and wait on waiting lists. It's about delivering services much closer to their own homes, but also into the way that they are used to going to see and access healthcare. So that's broadly the way that the plan works. There are quite a lot of detail then in terms of the trajectories and the underpinning plans in terms of the delivery, and then that's supported by a very complex MDS, which is really the very, very detailed components of the plan. So those are the kind of three aspects of the annual plan. I'll hand over to Darren on the financial components. There is obviously a very close piece of work that goes on between strategy and finance in the delivery of the plan, and the GMOs you see in front of you have been very much worked through the process of financial prioritization as well. So that is broadly how the plan is working for this next year, and I hope you're comfortable. I think we've kept you up to speed during the course of the year in terms of the plan's development anyway, and I think you've had an opportunity to feed into this. So hopefully this isn't a document that is not familiar with you. So that's essentially the plan for 24-25.
Shall I come in on that prompt, Chair?
Yes, thank you. Sorry, I was struggling to unmute myself.
Thank you. I know that Nuri had put a hand up, so I wasn't sure you wanted to handle it, but if I just do the finance bit. So page 6 of the report sets out the financial position. I think it's firstly really important to recognise that we have had a good financial settlement for 24-25. Colleagues in Welsh Government have worked really hard to get additional resource into health. So we're getting a 3.67% core uplift, that's £31 million. The wage award will be funded. Some of the gaps in energy costs have been funded as well. And we've had recurrent money for health protection for further faster. So a significant amount of resources sets the context of the plan, and hence why our ambition is to be tested through this plan. With a significant amount of governance, which I know board members will be aware of and have participated in since the allocation letter came in on the 21st of December, and there's been a very clear push and ambition to make the financial position as strong as it can possibly be, recognising it's a point in time and we need to do more. What we'll do in 2024-25 then is we'll use that allocation along with the £26 million savings plan to hold our own in year, and we'll also use some of the benefits realisation from that to reduce our underlying deficit at this stage, and I stress at this stage, from 54.8 million down to 50.1, which is the current forecast outturn for the plan. We know that that outturn is not something we're prepared to accept, and we need to do more. And what we already have planned to do is to look at another £25.6 million worth of options to further reduce the forecast, 14 million of which are related to choices we can make over the next month or so, and another 11 to 12 million related specifically to action we can take in very important areas of the health board activities, which wouldn't affect performance. This would be around our continuing healthcare resource, the way we undertake prescribing activities, working through workforce colleagues to recruit and avoid agency costs. So there are really meritable actions there which align very much, as Narissa has said, with the plan, the ambition and our vision to be a high quality organisation. So what we'll do is through April and May, we'll work really hard on those choices to bring them to life, and we'll assess those for quality impact. We'll also put together programme management teams so that we can start to look at the activities which require actually active intervention to improve. And we'll bring back to the May board then a further update on that, which I'm confident will result in a change to the forecast, the scale of which will be determined by that work. I'm also minded, and I've discussed this with some board members, to bring in some external support just to validate that we've done everything we possibly can. The board will recall we had a report in 1920, which was a really clear assessment of our underlying deficit and our opportunities going forward. I'd like to refresh that work and also use that work to look at our governance processes and our route to balance over 2 to 3 years. And I think that's really important as well in terms of the context of the ambition here. So we know we have more to do. We're very cognizant of that. There's an accountable officer letter which will accompany the plan, which will draw that out more than this report does. So that's the revenue position. And just briefly, Chair, because it's important, I just wanted to cover that at this stage we have a balanced capital plan as well. And that's based on a risk assessment. Capital plans are typically fluid through the year, and we will manage the risk in that plan as we go through. But there will be equipment replacement in that plan, there will be digital refresh in that plan, and there will be improvement to our environment where we can do that based on a prioritised basis. And the final point, again, because this is important in the capital perspective, is this plan also includes a ranked assessment of our capital prioritisation, which is an exercise we've run through Narissa's team. We've done a really, really excellent job. And in approving the plan, should we do so today, we're approving that prioritisation, which will be submitted in parallel with the plan itself, which may have been less obvious to colleagues who just wanted to draw that out. Thank you, Chair.
Thank you very much, Darren. Okay, I can see lots of hands coming up. Nuria was first.
Thank you both. First of all, I would like to say that I think the plan is really clear, and it's very clear what we're aiming for and where we need to be. So thank you very much to Narissa. I'm really glad to see the emphasis on clinical variation. I think this is a really tricky area to tackle, and one where I feel that clinicians are vital to make the best use of our capacity and minimise value. I wonder if there's a bit more detail sitting behind how we're going about implementing that and bringing clinicians along us. There is also a few areas where I welcome more assurance that we are taking a step forwards in the right direction. I am concerned about the population health section. In my view, we took a step forward in terms of we had some very vague ambitions, and we came up with some very robust actions as a result of the strategy that we produced for population health strategy. Now, we did struggle to deliver on those robust actions, particularly around identifying and allocating leadership to the required actions across the 4 pillars. But I am concerned that we will be moving back from those very specific actions to a vague narrative about embedding population health, which has been an aspiration for us and other health boards for a very, very, very long time. So I do welcome assurances that we are not moving away from those actions, and that as part of the plan, we are massively stepping up our efforts on delivery of those actions.
Okay. Do you want me to take
there's a couple more. One is around the virtual wards, and just having an explanation of where we are at with the virtual wards would be helpful. Yeah. And also in terms of whether we found them to be more cost effective.
Yeah. So I'll pick up variations first of all. So there's a section in the report about Bayway pathways, and some of that is about looking at pathways to start to eliminate variation, to get the pathway correct, to get standardization of pathways, and that's a good mechanism for doing that. But I think I would be fair to say that it's a very, very tricky area, because clinicians are clearly free to practice, and maybe my colleagues will want to come in here. So standardization and GIRFT are key really to ensuring that we do things correctly, and we do it once and we do it in the same way, and to embed that into clinical practice is very much through the sort of the clinically delivery routes. In terms of population health, I'll probably need to bring Keith into that, because I mean, obviously, as the author of the plan, it's about translating a plan into action, and I think it's crucial that we don't lose that, what are the 4 pillars in that plan, when we translate it into delivery. So that isn't the aim. The aim is to try to bed it more firmly into the organisation, so that it isn't just a plan that's sitting on a shelf, but a plan that's delivered within everything we do. And I think the pillars are important for us to continue to go back to. So I would say, when we've developed the plan, that sits much more in sort of strategic objectives, system visions, and that's the place that we really should be picking that up, so that it isn't just something that's in isolation. Population health isn't over here that we then kind of go back to a plan. It has to bed everything that we do and the way that we do it. In terms of virtual wards, Anjula, I'll bring you in on that because you're much closer to this than I am.
Thanks, Angela. If you're, were you coming in on something else as well, Angela, or on the virtual wards? You're on mute. There we go.
Just to support Nerissa on her on the statements around pathways and reducing variations and raising standards. And I think the bit for me is absolutely key in this is that clinical engagement, ensuring that we know what the challenges are so that we can then work on what is the best service delivery and the best pathway. I think the most important bit for me is that those pathways need to be integrated. I think we really need to ensure that we're not only targeting certain areas and really looking at that journey of the patient goes through many services, many timelines, and it's important that we are involving all our professions who will be inputting into that journey for that patient. So that's where I think a pathway then really develops when it becomes truly integrated. And in regards to the virtual wards, I think that is an example where we have started to look at those pathways and really looking where the patient starts their journey and where they end up very often. If that's we know that isn't always in secondary care because they return back into the community. So we really need to ensure that that service, that pathway is wrapping around the patient. The virtual wards are continuing to having a significant impact on our unscheduled care delivery because they're sitting in that space where they are receiving primary and secondary care referrals to really make sure that we are targeting the right patients. The outcomes and the sort of savings, particularly around bed days, admission avoidance, facilitating earlier discharges, are all measured as part of that service model, which I think is really important, and that data is available and feeds into when we are now looking at making those virtual wards, enhancing them into a 7-day service delivery and really making sure that they're now feeding into that frailty model you mentioned earlier, Chair. So I think it's evolving with the virtual wards. It's very much nationally regarded as a prototype of how services need to look like when we are particularly addressing our frail elderly population. So I think we're on the right track, but we need to continue to evolve and be agile in making sure that we are optimizing that service delivery for our patients.
Thank you. Thanks, Angela. On the clinical variation, so clearly there is work happening at a national level on GIRFT as well. Have we got a structure in place within our annual plan to develop that at a local level and focus on key areas?
So I think we've used the Bayway pathways as the mechanism for doing some of this, really, but we've done those on very specific areas. So it may be how we develop those going forward. So we've had pathways in cardiology, respiratory, MSK, frailty and diabetes. I think some of them have been more successful than others, but it is very much about how much clinicians engage in it. The MSK and frailty are probably the best examples of it. So where they really are driving out innovation and driving out waste really in the system and changing the way that the pathways are being delivered. I think diabetes, we've done quite a bit of work on it, but I think there's more work to do. There's gaps in service provision around diabetes that we need to fill as well. So, but that would be the sort of the main mechanism for doing that, which is described in the plan. But I'm happy to bring colleagues in that are more skilled in this area than I am.
Thank you, Nerissa. Deb, is that what? Yes, I'll bring you in.
Yeah, thanks, Chair. So, particularly with the GIRFT programme, so there are 5 or 6 GIRFT programmes of work now, particularly in the surgical specialties, that we've had the national reports from the team with. Urology was the last one that we were from. And we're at varying stages with implementing the recommendations of those reports. We're probably furthest ahead with ophthalmology because that was the first one that we had. Urology is the last one that we've had. We do have a group that's coordinating all of that, but I think it's fair to say if we review that, it needs a bit of work because our internal structures, our management structures in particular, have gone through so much change over the last 6 months that we've not really got the grip on as a health board holding it in one place as we'd want to.
Yeah.
So Gordon Staple is leading that work for me as the Assistant Medical Director for Service Transformation, and he's holding the ring on all of that. But the support for Gordon in bringing it all together in one place, we're now putting some emphasis on as we go through April. Most of the services sit within the Neath, Port Talbot and Singleton Services Group, and the organisational change process for that team is going to be concluding now over the next couple of weeks. So we'll have the people in post that we need to coordinate them. But that hasn't stopped us making the progress on the action plan. So we are taking forward the action plans and the recommendations. And most of them are pretty good in terms of where we are. No surprises, which is always useful coming through from those reports, where they've highlighted deficits, they're deficits that the services and us as a health board are aware of.
That is encouraging. Richard, are you coming in on this or more widely?
No, just generally, I was going to come in on the One Bay Way. So I think it's important as well just to remind board members what that constitutes. There were 5 work streams within One Bay Way, and we supported each of those with input from finance, from workforce, from digital, and from planning in order to develop those. I've just been having some conversations in the last week or so actually about where we've got to with those, because I think we now need to refresh that program. I think there are clear areas, as Nerissa has highlighted, of what's been achieved, particularly around musculoskeletal and around frailty. I think there are others where they've probably achieved what they needed to do, perhaps less transformative in what the output is, and there are others that maybe haven't achieved what they could have done. And I think we now need a view of where we've achieved in those areas, how do we move those on, because we'd be keen to make space in that program for the resource that's being put in for the next phase. So what have we achieved and how do we move it on? What do we now need to let go? There may be things that have been completed and don't need anything else. And thirdly, I think we also need a view, and perhaps diabetes is an area of this, where we haven't maybe achieved what we could have done. And how do we press ahead with actually the opportunities within some of those to provide further support for those work streams to really get out of it what we need to. So I think I've got a conversation with the execs next week at our formal exec board about One Bay Way, how we review what's been done and then decide the next steps to make capacity for the next phases.
Thank you. That's very helpful. Thank you, Richard. Right, Andy.
Right, thanks, Chair. So less a question, just more some observations. I think, firstly, just wanted to be able to thank the strategy and planning leads around the development, the IMTP. They've been really positively engaged with the Health Professions Forum, and they've visited us on 2 or 3 occasions within the year to ensure that we can contribute towards the development of the plan. I think from it's referenced in our report later, really welcomed the bringing together of plans into a single plan. I think that it's an important part that we referenced when we met more recently, and in particular the more recent addition of the actions with regards to targeted intervention, so that we can see all of our priorities all in one space within the health board region from across all of the professions. And I suppose that's just and to welcome lastly, just welcoming the real focus around quality, and that we're not looking at all the transactional stuff specifically, but actually referencing the fact that our plan is focused around developing quality and having an impact on the quality of care for our population.
Thank you very much, Andy. Very helpful comments. Rena.
Thank you. The only thing I'm confused about, Nerissa, is how this fits now with our interim or integrated medium-term financial plan.
Yeah.
Obviously, it's a 1-year only plan.
Yeah.
And we have a requirement for a 3-year plan.
Mm-hmm.
And in the past, I know we've sought, I suppose, approval from Welsh Government to submit a 1-year plan.
Mm-hmm.
So where are we in that sort of cycle? So that's one question. And the second question was linked a bit to what Nuria was saying earlier, that on population health, I fear that whilst in a sense we've got this lovely and I think very good population health strategy now, but without specific actions, that it could drift.
Yeah.
And I just would like to see more specific actions of how we're going to, because it says in the the detail here. That, you know, we need to have coordinated action across the strategic, tactical, and organisational perspectives to move this forward from transactional to transformational. But what are those actions? And I just feel as if I'm not very clear yet. Perhaps I'm missing it on what are the specific actions that we're going to be taking in next year to embed that strategy. Thank you.
Thanks, Rena. Nerissa, I suggest you cover the IMTP point, and then I was going to bring Keith in on Nuria's question as well, and things moved on. So I'll bring Keith in at that point.
Okay, the 1 year plan is simply because we can't submit a balanced position over this 1 year. So you get a 1 year plan as part of our targeted intervention. We need to look at how we get to a position where we get a balance over 3 years. So we will need to use the process that we're describing to get to a 3 year plan, so that we also have this 1 year plan in the context of a 3 year plan. As I discussed at the briefing session, the clinical services plan that really sits underneath the strategic objectives is coming to its kind of end of life, and we're reviewing where we've got to on that and what we've delivered within it, so that we can refresh that over the next 12 months as well, so that it'll be an informed process to develop a 3 year program. So it's simply a technical thing around the 1 year plan, but really we should be doing 5 year plans and 10 year plans, not and the vision is 10 years. So because 1 year is just a slice of what you see. So I take the point, and we should be getting a 3 year plan to get to a balanced position.
Thank you, Nerissa. That's helpful, and I will take this opportunity. I am keen that we do land that 10-year plan, that vision, at a high level. Of course, it's a high level plan, but I think it's very important that we have that umbrella direction of travel to keep us heading in the right direction, particularly over the next few years, which are going to be challenging. Keith.
Yeah, so thanks. So I'm grateful to Nuria and Rena for pointing out what they see as a risk, which it is a very real risk. In this year, I guess we're still in this year, 2023-24, we had a number of work streams or work lines in the annual plan which were related to the population health strategy. And whilst those gave, if you like, visibility to population health work, you both are aware of the difficulty we had in actually realising the ambition which was contained in those work streams. And partly that was because they were identified as population health work streams. So it was, we were still in the space of, if it was population health, it sits with a particular group of individuals to deliver it. I think that's what informs the phrase about getting into the tactical to operational. So we're very good at writing a strategy and then going and doing stuff and saying, look, we're implementing the strategy, but it's not implementing the strategy, it's just doing stuff. What we're in the phase that we need to be in now is seeing genuinely how we incorporate the aspirations in the population health strategy into that cultural change which Emma talked about earlier, and that means reflecting in the way that we do business changing. And we've had some examples of that in this discussion around more of a focus on outcomes. Are we actually clear about what we are doing for our patients? Are we achieving the outcomes that we should be, and are we achieving them equitably? And that links both to clinical engagement into what's the purpose of services, the quality agenda, how are we delivering our services? Are they patient-centered? Are they effective? Are they delivering good outcomes? And are they equitable? Is it the case that they're open to all who might benefit, and the outcomes that we deliver are similar to all who might benefit? So the population health strategy sits in that, and it also sits in with this idea of developing pathways, moving away from our long-term approach, which has been focused on services, and often in individual service delivery groups, to thinking about, well, we're engaging with people who may engage with a range of different services on their journey from the community through our through our hospital services, as if that's the path they take back to the community, or more frequently from the community through our community services, primary care and community services, whilst remaining in the community. So I think that the focus for this year will be on embedding an understanding of population health approaches in how we do business. And we've already had some really good engagement with primary care and therapies and the Neath Talbot and Singleton Service Group. We've also had very good conversations with Morrison Service Group about what does that mean for us to look at engaging, embedding population health approaches into how we do business day to day. I think that's where the immediate focus needs to be. That's about the tactical element, the how do we organize ourselves to deliver population health gain. So I think that's the work for the next wee while, and that will include bringing some other players who I've not mentioned, who may be a bit more reluctant to come into this arena, and saying, you know, this is not optional. This is an essential part of delivering quality services for our populations. So I think that's where the focus is, rather than on pointing to here are 5 or 6 initiatives which show that we're delivering population health, because I think that sometimes is a distraction from the longer term organizational shift, which is actually more important in that sustainable response and that sustainable approach to shifting the dial on population health. So that would be my view, and that does raise the risk of, well, if we can't actually point to specific activity, how will we know we're being successful in that? And I think we'll know we're being successful in that when we start to see what the proposals which come out of those service groups and the way in which services are being delivered, and how we measure the impact of what we're doing and be able to point to it, reducing inequalities, improving equity, and improving clinical outcomes. Those are parts of a population health strategy delivery, successful delivery of a population health strategy.
Thank you, Keith. And I think these conversations are being had in some detail at the Population Health and Partnerships Committee as well, which is very committed to this behavioural approach, which fits entirely with the One Bay Way as well, and other change programs that we're looking to do. But I think it does behove us all to continue to keep it on the agenda and to keep discussing it and to keep challenging ourselves as to whether those changes in approach, we are starting to see them. We're starting to see them through the plans that are coming through. Good. Okay. I'm going to come to Anne-Louise next.
Thanks. First of all, I really enjoyed reading the plan. It's really clear. It does give a very comprehensive view of the Health Board's plans for the future. My concern, my anxiety is that the staff generally in our Health Board are unaware. This is very high level. What they see when they go home is, you know, mum has had a 17-hour wait in ED, Mrs. hasn't been able to get an appointment with her GP, and as an ordinary worker within the Health Board, I don't know what's going on. I just see that I'm very busy. I don't see the way out of this particular hole. And I recognise that there are various communications, most of which are not read. I know from experience, they're mostly not read. Richard's very informative midweek message is probably only read by a tiny percentage, which includes me. And I'm just concerned that people still go home, and they're our ambassadors, aren't they? They're our messengers. And how do we let everybody from the domestics right up to the junior doctors who are really busy, all the clinicians, how do we get them to spread the message that there is a plan and it's going to be difficult, but we are going to get there, and we've got great moves? Because the ordinary sort of communications that the Health Board puts out and can put out probably misses 70% of the staff, and I don't have a solution. I just wonder whether somebody else has, and it's been thought about, because it is a major concern. We want positive advertisement, not negative.
Yeah. Can I come back on that, Emma? Is that okay?
Yes, no, please, and then I can see Sarah's hands up as well.
There's two bits. There's a bit about how you develop the plan. So the plan is developed from a huge engagement exercise. So it's not, you know, my planners sit in a darkened room and just write plans. It is about engaging with the service groups and check-in, who in turn engage with their own staff. And the strategic objectives are linked to the vision. And the vision was an enormous staff engagement exercise which predates me. So those two things are hugely engaging just in themselves. But I do think, and it's a conversation I've been having with Richard Thomas, about, you know, how do we get this message out? So how do we start to do more kind of workshops, more kind of engagement on towards? Now, in other jobs I've done, we did a lot of work on presenting the plan but doing it in a very simple way so that the people understood what it meant, and particularly the financial challenges, that they understood why it was better to be in surplus than in deficit, and how that can innovate and improve things, and what part they had in the financial success of the organisation. So I think there's a piece of work which I'd like to bring back, and it ties really to targeted intervention, as well as the clinical services plan and how we start to develop that, which is a much more engaged way of, it's not just a transmit. So I tell them about the plan, but it's about then getting ideas back about the plan. And I think we need to have a think about how best to do that, so that we're doing it in ward areas, we're going to them, we're doing it at night, and where you do that as a proper campaign, you start to get the message into the organisation about what it all means, and therefore it's not dependent on reading a midweek message or something like that. So, but it is tied back to the One Bay Way kind of brand, and making sure that we tie that back into the organisation. So I think I haven't got a solution, but where I've done it before, it's really important when we're in targeted intervention that people's heads don't go down, and that we keep staff engaged, so that they understand the message, and that is crucial about how we take things forward, really. So I think we've got a piece of work to do around the plan and the translation of that plan back to the organisation. But it can't just be a transmit, but it's been developed in a way that's not just a transmit. It's been an engaged process in the start anyway. So it's driven by the vision, which was a huge engagement event. It's driven by engagement with the service groups, so it's a bottom up, but we've got more to do then in terms of what that plan is telling us, I guess.
Thank you very much, Narissa. I'm going to bring Sarah in, because I'm sure she's coming in on this as well. Yeah,
I am indeed. Thank you all. And to reiterate what Narissa has said here, for me this provides a really great opportunity for us to engage with our staff. We've got a really clear vision, a plan that is really clearly linked to it, and it's based on what our staff have said is important. So we mustn't lose sight of that, and I think that's an incredibly powerful message for us back to our staff, particularly given all of the challenges, that we've listened, and that this is an opportunity for us to listen to all the ideas that they had about transforming our services, an opportunity for us to think about how we make ourselves more effective in the way we work. If we think about all that we know, and Louise, I respect your point, it's something I'm concerned about as well, and I don't think you can ever engage and communicate enough in that space. And what we've got to do is respect the fact that our staff like to engage with us in different ways, and therefore we've got to have a different variety of means and mechanisms in terms of the way that we engage our staff. You know, how do we ensure we reach the porter on the ground as well as reaching the senior clinician on the ground? The way we engage with them is going to be different, and we've got to respect that. But actually our One Bay Way really gives us the opportunity to do that with some really key high-level clear messages that reflects the fact it goes back to what they've said is important to us. Supporting staff with psychological safety and their well-being is going to be incredibly important, and I think that's important for us to consider when we think about how we engage and communicate with them. there's got to be a two-way feedback. This can't be tell them what we're doing. This has got to be a continuous loop of engagement with them to understand, to make sure that they feel safe to be able to feedback on the things that we're not getting right in the plan as well. So what the plan gives us are really clear outcomes that we can embrace with our staff and share with our staff. And actually for me, we've got to really think about how we do that by working with them. We've also got to remember the opportunity for our engagement with our trade unions here. We have a trade union compact as part of that plan, and that talks about how we work together in terms of ensuring that message. And I think that's a really powerful opportunity for us as well. They were part of shaping that vision. They hear some of the noise, some of the challenges, some of the difficult work, difficult things our staff are facing. And that gives us an opportunity to learn and readjust. So that any engagement becomes a living and breathing part of the way that we work. And for me, one of the most important things for that is our language and the way that we do it. And that most important reassuring message that this is because what our staff have said is important, and that's providing high quality care for our patients.
Thank you, Sarah. Does that provide you with some assurance, Anne-Louise?
It does. I'm more reassured about the plan that Nerissa says she needs to bring back. I still feel that there is a risk of falling between two stools. I understand what you say, Sarah, about the well-being and so on of staff. That's fine, but there are those silent minority who are the ones who we miss every time when we're communicating, and they're the ones who probably are most in need of support, and to recognise when they go home that what is happening is going to make a difference to their children's health in the future, that kind of thing. And I'm not completely sure that the way that we've done it in the past is necessarily the way that we're going to get this across, because we know from Emma pointed out in the Times yesterday, the front page headline was that the level of confidence in the NHS is the lowest it's been for a long time, and those are the messages that come across very strongly. The positive ones get lost, and it's actually trying to turn that around. And we know from the results of the survey that there are major issues that are going to be difficult to turn around. So there are all sorts of things that need to be done, but it's bringing it together and making sure that we tackle every rank in the health board.
Yeah, I think that's right. I think that's right. And how do we not lose this from the agenda in terms of picking it up? I mean, clearly, it's not, the IMs aren't going to lose it, are they? And the executive team as a whole is more than conscious of it. But I just wonder whether there is some way in which we can come back to this discussion in some form.
So,
yeah, Nerissa.
There's two things. There's something about the plan, and then there's something about how we operate as an organisation, because the plan is a form of words. It's got a vision and a way of describing what we want to do, and targets and all of those things that go with it, and money, and that's what the purpose of the plan is. And then it's about how we behave as an organisation. So if we take a population health approach to things, as Keith's point, are we behaving as a population health driven organisation? And for me, I don't, people can give me lots of documents to read. I don't really believe them. I believe what I hear. I believe what I see. So my test as an individual is, okay, you say that, but then I'll wait to see whether or not you actually do it. And maybe I'm cynical, but I think most of our staff would probably look at it as great plan, lovely, really glossy, like nice colours. But what does this mean in terms of the translation, and how does it make a difference to me today? And do I really believe these people kind of are serious about doing these actions? And that isn't a form of words, that's a form of deeds, and therefore you've got to keep making the kind of, it's not just a one-off exercise, it's a constant loop, really. So I suppose we need to bring something back to you, I guess. It's not a finished article, it's something that we probably need to go away and have a think about. And with Richard, I wish Richard was here, because he's got some good ideas about how we might be able to translate this. So we'll come back. Richard and I'll bring a joint paper, I think, to I've discussed with the execs about how potentially we can do that. But it isn't, the vision is about a different way of doing things. It isn't about targets. It's about a different way, a different compact with our staff. And when you do it like that, and a compact with our partners, and the way that we deliver services, when you do things like that, you change fundamentally the way the organisation feels, and that's really hard to measure. So I think we need to bring something back. But I absolutely take the point. The plan is a point in time. It's the delivery of it, and it's not just the delivery of the words that's in here. It's the way that we do the business that underpins those words, which is the vision, to be fair.
Yeah, so on mute. Thank you, Nerissa. We will take you up on that plan. I think that will be very helpful. I'm going to bring Sarah and then Richard in before I come to you, Nuria, because I'm sure they're both coming back on that as well.
Thank you. And Louise, your point about how do we ensure those quiet voices, for me, that really links to psychological safety and a strategy around that. And one of the key things in terms of that is about ensuring we have multiple channels to communicate, engage. If I reflect on our Guardian service opportunities, we're hearing a lot of things from them in terms of our front door and the challenges it feels like there. That gives the opportunity for us to really understand, engage directly with them, and through the Guardian service, for example, in terms of the plans that we've got. So there are lots of mechanisms to ensure that those staff who perhaps are hearing the vision and not believing it or seeing it in a different way, it means we have different opportunities and mechanisms that already exist in terms of our Speaking Up Safely agenda that allows us to reiterate those key messages in an appropriate way that connects with our staff, to reassure them. So hopefully that helps.
Thank you, Sarah. Richard.
Yeah, thanks. I think colleagues have said a lot, actually. So just a couple of points. Nerissa's quite right. Richard isn't here today as the Director of Insight Communications and Engagement. Richard's got a lot of ideas. There's a lot we already do. And I think that challenge is a fair one. How do you reach 14,500 staff that makes that message relevant to each one of them and what they do every day? We're very conscious that not all staff have good access to email, so not all of our communication is email. There's our social media channels. There's the hard copy paper that's available outside all of our sites. And then finally, I think an important element of that is also the team brief. So the team briefs that we do every month is something that I typically present to our service groups. The service groups present it in terms within the directorates, and the directorates present it in terms of their services with the same message. I think the challenges for us will be, and it's a fair one, is how to make that. So Nerissa's outlined how we engage staff in developing the plan. We can't possibly engage all 14,500 staff, but there's obviously a significant number of our services that are there. How do you socialize that conversation so that people who are engaged tell their colleagues, so that it becomes a corridor conversation that's not a broadcast, and I mean that not a broadcast in terms of something that's in the middle of the week message or the team brief, but it's something that you socialize that message and actually you stimulate that conversation within our teams, and that's how I think you spread it, rather than necessarily be stuff that people log into the Facebook page, because it's the purpose of the way that we cascade the team brief is to try and make that a consistent message, but one that's framed that becomes relevant to each clinical area where it eventually ends up. I'll pick up when Richard's back next week, but we might need to have a think about, the types of message we put out on social media. We tend to put newsy type stuff on there. It's maybe socializing some of this, and as Sarah says, it's all backed up by how do you hear those quiet voices? How do you encourage people to speak up? How do you make sure that people feel safe? What mechanisms have you got there? Because I guess to some extent, unless people know what the plan is, they won't actually be informed to know what to speak up about. So it's all of the above, but we're very, very conscious of it. And I think Narissa's suggestion of maybe a joint presentation at a future board, maybe in May, around the comms aspects would be really helpful. Thank you.
Thank you, Richard. Nuria.
Well, first of all, I would like to thank executives for the level of reassurance that you've provided today. It's been really, really good to see the interlinks and how you're all thinking together. I think it provides quite a lot of reassurance in terms of the plan. I was going to pick up on the socialising element that Richard has just picked up, but because I think that the point that you've made, Narissa, was the one that I wanted to make, which is if we're really going to be making our efforts on population health, equity and equality in this organisation, then it needs to be part and parcel of everything we do, our behaviours and the way we operate. And we need to be able to demonstrate that, which is why the equality impacts become really important. I think the other side of this for me is around it's not just about psychological safety, it's about proactively, and Richard touched on this, is about proactively reaching out to seldomly heard voices in our organisation. And we need a plan to do that and understand how we're going to engage them and what the role is for everybody in the organisation. And I do take Keith's point that population health ultimately is everything we do, but that needs to be reflected in our plan. And I think that's the step for me that we need to take, if that's what we're proposing.
Okay. Yeah. Okay.
Thank you, Nuria. That was a really helpful discussion. Before we move on, I think we do need to just, I don't want to bring the conversation back to a less happy area, but the financial outturn that we are predicting is not one that we would want to be putting forward. And I think it's worth just reflecting on that as a board. There has been a significant amount of challenge provided to Darren and the team to drive this figure down. And I just really wanted to give Darren and Richard the opportunity to sort of, for the record, explain where we are, how this fits with the direction of travel that we're talking about, and the importance of being realistic. Which is where we were last year. This time last year, we were also putting forward something we didn't want to put forward. But I think there is just something I would just like that discussion to be had out in public. Darren.
Thank you, Chair. So just in response to that, when we look at the shape of the finances and where our start point would be this year, after all that money comes in from Welsh Government, but before we make any internal savings, we're about £85 million away from zero. Typically, over the last 4 years since I've been in post, this organisation has delivered between £24 and £30 million worth of savings every year. And to different degrees, that's become recurrent or non-recurrent in each individual year as well. So what we've done with this plan at this stage, and I'm very keen to stress it's at this stage, is show that we'll stretch ourselves for £26 million worth of savings to come off that 85 as effectively doing what we normally do, business as usual. Me engaging the conversation around the staff is really interesting. We're talking to different layers of service groups at the moment. Our service group directors are talking lower down to the budget holders around small savings, which aggregate up to big savings alongside the big system savings. And there are another layer of further choices to slow down some of the investment we had ambition to do, and that's what happens when you get into these types of financial challenge, which adds another 8. So we'll go from 85 to 50.1, and that's the kind of normal challenge. There are then 2 waves of other things that we can do. Some are very distinct choices, and as Narissa's very clearly pointed out, at the moment, the money and the delivery all hang together because it's an integrated plan. We could choose to slow down our investment in planned care recovery. That would affect the trajectory as stated. But that would release resource, and we've made some of those decisions this year to get to the control total. There are other things which are very meritable to do, which are less about choice and more about us improving our service delivery. We've talked about shift left, we've talked about virtual ward, we've talked about being true to a healthier Wales, which I believe we have, and we've implemented a significant amount of our acute care clinical service plan as well. So that's in place. That's a platform off which to build. And what this plan doesn't do yet at the 50 million mark is say, okay, when we go at CHC in a very constructive and appropriate way, when we look at prescribing in a constructive and appropriate way, when we look at our workforce, when we look at medicines and all the things that are then potentially variable, we can do better. But I need the certainty that there are granular plans behind those to have the confidence to advise the board that deficit can come down. And we'll do a lot of that over the next 7 or 8 weeks. And then we'll extend that further with the external support that I described earlier to address some of the really important comments that the board has made around the longer term or medium term financial plan actually, and whether we can get back to balance next year, certainly within 3, and embracing some of the other really good discussion topics we've had around quality and pathways. There is no dividend for quality improvement in this plan. Infection costs money. High quality doesn't actually cost a lot. It actually drives benefits into the system. The pathways, when they're reorientated, will take cost out of acute. And we've got some demonstrable but smaller examples of where it has released resource, and we've moved the resource around our system. So those things are there to come, and that's more about the sort of shorter to medium term. But in the next 8 weeks or so, a real bite around clear leadership on key issues. I think it's huge opportunity and really positive opportunity around our workforce. We have high sickness levels. We can bring people back to work, support them, recruit colleagues instead of agency staff, and make the environment a good place to work. We'll have all of those benefits which affect staff and patients, and I'll get the money out. So I think there's huge opportunity in the 25 million we're describing to date to do the right thing and get money out without destabilizing the plan. And there are further things we need to then identify to get closer to the control total of 17, and our very clear ambition, and then be very clear with me, to get to that sustainable position, because that gives us other choices and freedoms which we have been able to make previously, and we're just holding back on some of those at the moment because of that, the need and the scale of the numbers. So I hope that frames that, Chair.
Yeah, thank you. Thank you very much, Darren. I'm not seeing any more hands. Are we content? We have to approve this annual plan. Richard, yes, excellent, thank you.
Thank you. No, I was just going to add, I completely agree. There's a huge amount of work gone into getting us down to the 50. We have a degree of confidence that that will go further. It's just having now some further time to refine down and refine and hone those plans to have a line of sight down by a further 25 or so. I think if you look overall at the scale of the ambition there, I think I would point out a few things. I think we have a track record of delivering what we say we will deliver on the money. So I think that having that ambition to drive that down further towards the 17 million control total, with an initial look at how we get down by a further 25 is the right approach, and appreciating that it's not what we would want to be declaring, but what we're also declaring at the same time is a significant way towards that with a route to go further. I think it's also important to frame, given what, as Darren highlighted in his introduction, what we have delivered recurrently over a period of years. We've delivered what we said we would on the money. It's then making that commitment towards a 3-year plan to zero, and describing it in that context, because that is important to us. I think the ask in year to get that level of savings up the system without having an adverse impact on services is huge. But what we are doing as part of this is looking at, as Darren has described, the benefits of what we're planning in year, that we haven't yet got a straight line of sight to what the financial benefit would be, for example, of reducing those healthcare associated infections, of making improvements to our ward estate, and then getting those the more detail on those plans and the benefits over the next 7 or 8 weeks, as Darren described.
Thank you, Richard. Okay, I'm going to ask the board to approve the annual plan for submission to Welsh Government later this afternoon, along with an accountability officer letter. I'm seeing nods. Great, thank you very much indeed. And I would just like to put on record my thanks to Narissa and her team, to Darren and his team, but also to the entire exec board, because this is a plan that pulls together the entirety of our operations and what we do in a very clear way. And I know that there's an enormous amount of work and debate and pulling apart and putting back together again. So thank you very much. All right, so I'm going to cover the next item. We're running slightly ahead of schedule, but not that far. Actually, we're actually running about on schedule now. So we've got one more item, and then we're going to take a lunch break. And actually, we don't have that item because it is the Emma service review, which is going to be deferred to a special board meeting that's been arranged for the 10th of April. As Richard mentioned in his chief executive report, there's been quite a lot of toing and froing on this. So that will be that item will be deferred to a subsequent board meeting. So I suggest we take a break now, and we'll come back at 10 to 1. Is that okay? Fab. Thank you very much indeed. See you shortly. Nahanda. Welcome back to the second part of the Swansea Bay University Health Board public board meeting. We are on part 4, people and digital, and our first item is item 4.1, which is to receive the key issues report from Workforce, OD and Digital Committee.
Hello, apologies, Emma. I've stupidly jumped into a Teams meeting in between. I can't wrestle my camera back, so I am here. So I'm lurking in the background, but I can see and hear everyone. So happy to give give the summary of the report. As you can see from the paper, there's no significant matters to draw attention to the board, but there's some kind of key points I'd like to draw attention to. We've had a strong focus on sickness absence as part of Workforce, OD and Digital Committee, particularly to better understand where we are kind of benchmarked against the rest of the health boards in Wales, as well as an ongoing sickness management audit. So there's kind of sharing of best practice, particularly from the Morriston service group, so we can see across other service groups, as well as engagement from OC Health and Wellbeing, just to see how we are best supporting staff with some of the ongoing challenges. From a workforce efficiency perspective, a new locum dashboard has been created, so it allows service groups to better understand and interrogate their locum spend, particularly long-term agency locums, and that kind of that interaction supports the medic on duty system too. So that's a piece of work that's going to improve reporting and scrutiny, particularly against locum spend. Just a point around the digital strategy update. I think, well recognised our wider work in this area over a period of time. So I think our digital maturity as an organisation has been well discussed at board before. This ongoing work around, I guess, the next iteration of the digital strategy, both with some external organisations who are helping us to better understand this, but also kind of broad co-construction of our digital strategy across the breadth of the organisation, to think about how where we need to be kind of now and over the next 5 years, but also how that integrates and links with broader Welsh Government policy and strategy, digital and data for integrated digital health and social care in Wales. So that's an ongoing piece of work, but with a very, very strong staff and patient engagement piece. And that's obviously getting a lot of attention at Workforce, OD and Digital, but that will be coming back to the board again in the future. It's probably remiss of me to say to recognise the ongoing kind of cyber resilience issues. I think across a lot of public digital infrastructure, I think we're doing very, very well, but we are talking about kind of nation state activity and a very, very vibrant and challenging threat landscape. So that is the health board working with both the Welsh Government's kind of cyber resilience unit, but also with things like the National Cybersecurity Centre to maintain integrity and resilience of our systems under a very, very challenging threat landscape. And then finally, just to acknowledge, obviously, a number of, as you can see from the documents, a number of policies and reports have been approved, but just to draw attention to the Workforce Equality Plan and Annual Equality Report, which will be published on the website by the end of the month. A broad discussion, particularly with regards to the equality duty and how that's informed the strategy. But I think there's probably some lessons to be learned around potential limitations in some of our ESR data, and particularly other types of quantitative and qualitative data that we can use to better inform some of this work going forwards. But I'll leave it there and happy to take any questions and comments from colleagues.
Thank you very much, Tom. Tom Crick, our independent member. Any questions for Tom? Matt?
Yeah, thanks, Chair. I guess just to build on Tom's points there on where we are from a digital perspective, it's been quite a year in terms of learning what we need as an organisation. Clearly, we're not at a starting point. We're well placed with a number of solutions that we have and how the organisation, how our staff are starting to work more digitally. But over the last 6 to 12 months, we've not only done a piece of work on our digital maturity with the HIMSS framework, and also a survey around what our staff think of our systems, But also now we've done this piece on developing our digital strategy over the last, an intensive piece of work over the last 12 weeks, where we've now got a draft strategy which aligns to the One Bay Way, which will see us through for the next 10 years of where we want to be to digitally enable the organisation. And that also comes with a 3-year roadmap, as well as then a 1-year mobilisation plan, which will be an intensive piece of work for not just my team, but for us all working together to unlock some key things. Finance being one of them moving forward. Clearly, this is going to need investment if we're going to deliver whole-scale digital transformation, but also some of the fundamental capabilities and capacities, as well as the trying to find the right way of working effectively with national colleagues, both Welsh Government and DHCW and leads in other health boards as well. So it's going to be an important year for us to do that mobilisation plan, alongside, of course, the commitments that are in the annual plan for digital delivery, of which there are a few big ticket items in there. But I think we're in a real positive place to take this forward. And we'll get into a little bit more detail about it in an IM session that we have over the next month or so.
Yes, thank you. I think we'll look forward to the IM session, actually, and the relationships across Wales and the accountability at each level, I think is important to understand as well, so that we can drive this forward with maximum effectiveness. So thank you both for that. Are there any questions? No, I'm not seeing any questions. Great. So we now move to the annual workforce equality report. Sarah.
Thank you, Chair. So just bringing our annual workforce equality report for you today for noting as follows: presentation at the Workforce and OD Committee in February, where approval was sought for publication on our external website, which was granted. This is part of our public sector equality duties we're obliged to issue on an annual basis, and this reflects the figures reported as at 31st of March 2023. Data resourced from our ESR system provides a profile and analysis of our workforce. Happy to take any questions.
Thank you very much, Sarah. Any questions? I guess the only observation I'd have is that I got very excited when I first read it, and then actually what we collate it would be good if over time we can start to develop something ourselves that is meaningful for the workforce and linking it in with some of the work around well-being, inclusion, and other things. It's quite as always with these sorts of national things, it's quite functional, isn't it? What we actually collate. Yeah.
Would you like me to respond there? I agree.
Yeah,
it's presented in the format that has been requested by Welsh Government. Nonetheless, our people strategy provides an opportunity. This is a key people aim for us. And in terms of our journey around the digital world, which Tom has referenced, Workforce and OD Committee, we are looking to shape a dashboard. Part of that, in terms of our aspirations, will include referencing to our demographic and truly understanding what that people aim and how we achieve it is. We're on the journey in that respect, in terms of encouraging our staff to utilise ESR. You'll see some gaps in the data. They're not as where we'd like them to be, and that is part of our cultural trust across the organisation to encourage people to utilise and to share that data with us. So your points are noted, Chair, and I agree.
Thank you. Thank you very much, Sarah. Okay, I'm not seeing any hands on this one. So I'm going to move to the next item, 4.3, to receive a report on staff resilience and well-being. And I'd like to welcome Paul Dunning on this. I know you'll introduce him, Sarah. Thank you.
Yes, I will introduce. I'm hoping my colleagues will assist with the PowerPoint presentation, which was attached in the pack, where, assuming you've noted this, and we're just going to run through some of the slides that we've got. Are we okay to do that? In the meantime, perhaps I'll set the scene. That's really great. Thank you very much. So, recognising our vision to be a high quality organisation, a real cornerstone of what we've heard from our staff was to create an environment where they feel empowered and able to flourish. And this is really at the heart of what we're seeking to do. It's key to our One Bay Way. We want to ensure good, high quality work. A number of our people aims, if you want to go to the next slide, our key people aims as part of our strategy. Next slide, please. Are we okay? I will continue. In terms of slide 2, it sets out our people aims across our people strategy for the next 5 years in terms of helping us to create that 10-year high quality organisation. 2 of the key people aims there relates to having an engaged, motivated and healthy workforce. Equally, to have leaders that live our values, and this really reflects the conversation we had before. Part of enabling the strategy to be part of everyday life really is dependent on how our leaders, how our managers engage with our staff around that and truly live our values so that it feels like that on the ground. The slide sets out the detail in terms of what those are. I'll assume you've read them. Happy to take any questions in terms of them. If we could do slide 4, please. Next slide. We've recognised today that our sickness is not where we need it to be. It's not where we want it to be. But what we need to do is ensure we really deep dive in to better understand why the sickness absence levels are as they are. For example, we found within our Morriston service group that a number of our absences relate to challenges at home, perhaps relating to caring and bereavement. So before we jump in and seek to address and tackle that sickness, the way we do that becomes incredibly important. And for me, it's not just about application of a policy. This is far more about understanding the challenges our staff have and helping them, engaging with the capability of our managers to really, really think about how we can support our staff to be back in the workforce fit and well. The next slide, please. I think it's important for us to recognise it's really challenging out there. There are a number of factors that are impacting how it feels to work in the NHS. We've reflected that in our discussions already this morning. Some of those are highlighted up there. Recognition that we need to do what we can to support our staff. That will help reduce our sickness. It'll bring them back to work well. But we've also got to ensure that we think about the preventative action in place that we need, how we enhance our services, and I'll let Paul come to that in a moment. We've got to recognise that nationally there's been an increase in sickness absence. It's impacting in some areas of the UK more than it is others. A number of people out of work is increasing, and I think that's an important national context for us to consider. Cost of living is having a significant impact on the pressures of our populations, and that includes our staff. Mental health challenges are increasing, and our frailty work has actually highlighted we have one of the oldest populations in the UK within our health board area, and we're starting to see how those caring responsibilities are really impacting on our staff. All of these factors are really important in terms of what we do next, in terms of managing that sickness absence level and really focusing on ensuring the well-being of our staff. Next slide, please. Social partnership duty. This is an obligation that comes into force this year, but the good news for us is that it's already very much part and parcel of our people strategy. I've referenced before our trade union compact. That goes to the heart of ensuring that we really fulfil this duty, and that it focuses on ensuring that our people strategy is a collaborative one. It is one we will implement with our trade union partners. So we're already working with them in terms of fair work, and that forms part of what's known as our best practice review. How we deal with the more tricky situations with our staff often defines how people feel when it comes to working for an employer, and our best practice review really looks at how we're improving those processes and avoiding harm for our staff where at all possible. And all of this feeds into our social partnership duty. So it's reflecting what we're already focused on and what we're already doing. I'm going to hand over to Paul now, who's going to talk about the preventative work, which is really at the cornerstone of where we want to ensure our staff well-being. Thank you, Paul.
Thank you, Sarah. Nice to see the board. Thank you for the invitation to present some of the work that we're doing to support staff wellbeing. And as Sarah said, we're very much in the space of supporting staff who are struggling with their health, but equally trying to work more in the preventative space. So I won't go into detail on any of the slides, just highlight a couple of key points. I think the key point on this slide is to, again, just demonstrate the breadth of proactive and preventative support. We have seen an increase in referrals to the staff wellbeing service over the past 12 months, a 12.5 increase. And I think just a point on this slide, we are supporting more staff in the suicide prevention space, and we are collecting outcomes and helpfully demonstrating that over 90% of staff who disclose suicidal ideation or suicidal plans at the start of intervention no longer have those thoughts or plans at the end of intervention. Next slide, please. Lots of focus on occupational health over the last 12 months. We're really reducing our waiting times with the introduction of a new management system, which is helping to digitize the whole process. So managers now go online, fill in an online management referral, which means that we can get advice, support and recommendations back to managers much more quickly in order for them to help support sickness absence and to help staff remain in work. Next slide, please. Just in terms of assurance that we're doing what we say on the tin, this demonstrates pre and post outcome scores for people who've referred to the staff wellbeing service. What we want to see on the right-hand side, which is a post outcome scores, are more sort of mauve, purple and yellow, which indicate no symptoms or slight symptoms. So you may be able to see, it's very small, that we are definitely helping staff to manage symptoms around anxiety and depression, probably the #1 referral reason to our services, and also reducing pain and discomfort through the physio interventions and helping people to get back to usual activities, which obviously includes work. Next slide, please. This is just an overview of the preventative kind of interventions that we're taking. The green squares on the right are the new interventions that we're putting in place from April. So just to focus on staff health checks, we've had some additional resource to enable the OC health nurses to undertake preventative health checks for staff. So being able to kind of help staff understand their BMI, BP, cardiovascular risks. We're hoping that we can also include diabetes checks and cholesterol checks. So again, just helping staff to identify any red flags that they may need further support with and to get into that early intervention prevention space. Next slide, please. This slide just, as Sarah said, demonstrates the sort of bespoke approach that we're taking to high sickness absence. So we're working with BP and HR colleagues to make sure that for those areas that have high absence levels, we really do understand the issues and then put in place individualized interventions to help support managers and staff to remain in work or to return to work as quickly as possible. And you may have seen the Project Wingman Wellbeing Bus, which has been on the health board for the last 10 days. We had some resource to support this. It's delivered by airline steward staff who on their non-working day volunteer to provide our staff with free snacks and drinks and sort of relaxation space on the top deck. And it's been really well utilised. I think we've had over 500 staff access this over the last week and a half on the main sites. Next slide, please. So we do have data that suggests if the staff wellbeing service wasn't doing what it was doing, sickness absence may well be higher. So some of the outcomes that we collate demonstrate that 82% of staff believe that the wellbeing service helped them to return to work sooner, and 47% of staff who were still absentees at the end of our intervention believed that the support helped them to return or move more closely to a return to work. There is some emerging evidence from CIPD, which they referred to as the kind of wellbeing paradox, in that emerging evidence suggests that despite investment into wellbeing services across a number of sectors, sickness absence in some areas still seems to be increasing. Next slide, please. So in conclusion, we will continue to work collaboratively with colleagues to ensure that we're providing evidence-based interventions for our staff to help them to remain well in work or to return to work as quickly as possible. We'll continue to identify trends and develop bespoke interventions accordingly, and to help and support, as Sarah said, high quality and good work, because the evidence does state that good work, and the emphasis is on good, high quality work, really does support well-being and health. And then the final slide is just for the board to note the recommendations, particularly as we continue to support the 10-year vision and the people strategy to enable a healthy, motivated and engaged workforce. Thank you. I don't know if there are any questions or comments.
I'm sure there will be, Paul. Thank you very much. And of course, this is a fundamental part of the discussion we were having earlier around the annual plan and indeed our 10-year vision. So it's really good to see this coming. Nerissa.
I'm not used to Zoom. You put a slide up, Paul. It's a really helpful presentation. Thank you. It's a really good way of kind of presenting it in terms of the early intervention rather than kind of dealing with the problem after the horse has bolted almost. So, but I suppose there was a bit around mental health. So you'd focused in on mental health, and I couldn't work out whether there was a specific problem in there or whether they were just interested because of the nature of the service.
I'm not sure what you mean, Nerissa.
There's about the third but last slide, some practical things that you were doing, and you picked up with some of our problem areas, you said, and you said mental health, was that?
Yes, so in some of the areas where we've done bespoke work, where sickness absence is particularly high, if mental health is recognised as the key contributor, we've done some bespoke work.
Oh, okay, rather than
mental health support.
Yeah, okay, fine. Okay, got you.
Okay.
Thanks, Nerissa. Right, Anne-Louise.
Thanks. In one of the slides, you refer to the big conversation demonstrating that 20% of staff disagree or strongly disagree that managers and leaders are responsive towards staff when they face problems in my area of work. And that finding was reflected in the outcome of the survey, the recent staff survey. What I would be interested to know is how will you drill down into that information, because obviously the big conversation and the outcome was published last year, and I just wonder what's been done to identify those areas where managers are perhaps either haven't had enough training or have an attitude towards their staff that isn't conducive to well-being in the workplace, because unless we identify the particular areas and deal with it, we'll keep having that response in surveys and staff who are unhappy and leave.
Yes, I mean, in some ways, the solutions are different, aren't they? They're two different issues. Sarah, do you want to pick that up?
Yes, that great, thank you. So there are a number of ways that we're already looking at that and need to keep doing. So we have our staff survey, which we haven't yet had the drill down data that allows us to see where across the organisation some of those key trends are coming. We should be having that next week. What will then happen with that is that we will correlate that data with the data we've already got by our BPs working with our service groups to drill down to look at where are hotspot areas. With that also our Guardian feedback that allows us to drill down to particular areas, that allows us to share that. We have constant engagement with our trade unions in our formal forums and our informal forums, and part of the best practice review allows them to come to us at any time and have a conversation. Often like bringing us a number of things to tackle and that we nip in the bud around some of those issues. Where we possibly can. We get some intelligence from our listening sessions with our staff across our OD service, and just generally in terms of ensuring we've got our ear to the ground with that, from what our leaders are saying, from what we're hearing, but in terms of our visibility and presence on the ground as well, talking to staff. You know, there's an awful lot of value in that really good conversation. I spent some time doing the industrial action last time, just talking to our staff in the ED department, some of our front door, in terms of how that feels. You pick up an awful lot of intelligence through those conversations that really helps us to piece all of that together.
Thank you, Sarah. Did you want to come back, Anne-Louise?
I just wonder whether when these staff survey and the drill down details come back, whether in a couple of months it could come back to us so that we understand just what work has been done, because it's an ongoing issue. It's clearly been going on for a long time, and I think that the acuity will be higher now because of the issues that are publicised about the targeted interventions and so on, and that can have an adverse effect on the way in which people perceive the organisation in which they work, and anything that can be done to reverse that or at least mitigate that would be helpful.
I think that would be helpful. When would that be? Do you want to take it away, Sarah?
Happy to take that away. What we will be doing is using that data in order to compile service group plans that will correlate and link back to our people strategy in any event. So happy to take that to our ward committee in the first instance, or here, whatever suits the board.
I think that sounds a sensible way forward. Thank you. Okay, Rena.
Thanks, Sarah and Paul. The question I was going to ask is that, I mean, how well are we enforcing, well, not enforcing sounds a bit, but how well are we adhering to our sickness policies? Because there has been anecdotal evidence from people that, you know, managers don't necessarily follow the stages that they need to follow in relation to somebody. And I am concerned about that, because either way, if it drifts, the early intervention things that we were talking about won't be, you know, put in place, and often it'll drift off into a longer term sickness than it needs to be. So I just feel it is quite important that managers are complying with the requirements of whatever our sickness policies are. Thank you.
Yeah, good question. Did you want to come back on that, Sarah?
More than happy to. So I think we could do better, being really honest, and I think there's always an improving opportunity here when it comes to managing sickness. I think we need to think about the capability of some of our managers, given the challenges that they're facing on the ground. It feels very challenging to have those difficult conversations at times, doesn't it, when they're fighting the fires, so to speak, in terms of the capacity increasing. And therefore, the way we do that is incredibly important. So for me, having a very coaching style, we've got to get better at timescales of our sickness policy. Rena, I completely agree with you. There's a challenge within the capacity of the workforce team to be able to do that. What we don't want to do is police it, because actually all that will happen when you police something is you remove that, and it doesn't create resilience in terms of the way we do this. So this is about part of our work with our trade unions equally in terms of how they support staff in those spaces and how they react to those formal meetings. We need to see them as spaces that are positive and supportive, not sanction and impact in that negative way. So I think it's a real challenge, and I think it's something that we've got to really focus on in terms of achieving that reduction. But it's the right thing to do, because it's about bringing people back into the workspace. And it shows the longer you're off, the more challenging it is to bring our staff back in. So it's absolutely the right thing to do, completely.
Do we provide training for all managers as part of it? Because it's not there's a difference between adhering to the policy, and the policy is a good policy, but we do need to adhere to it, and how you do that, and the way in which you speak to people, and it's that sort of that balance which it doesn't necessarily come naturally to everybody, does it?
No, indeed. We do provide managing attendance at work training. As you acknowledge, it's an all Wales policy that's recently been reviewed. So it's very much values focused and putting the person at the centre. So it's echoes the sentiments of our strategy. We do training on it. But for me, it's those coaching conversations that encourage you to do them in the right way and manage this process in the right way. I'd love an army of staff to be able to do that, but I recognise, given our challenges, that won't be possible. So what we've got to do is really think about how we get people who champion the positive outcomes of managing this proactively, working with our trade unions to do that.
Great, thank you, Sarah. Jean.
Yeah, sorry, I'm still on a sideward tilt, and I haven't been able to use my video rotation button to rectify it, so I seem to have no control over it, so I do apologise. I can assure you I'm not lying down, Emma. Paul, thank you for the slide, particularly three elements that we are introducing. I was interested to understand the staff health element. Is that a self-referral? So does someone ask you to undertake that? Or do you have a program of works that's driven by the data analysis of maybe, you know, departments with higher percentages, or have you got a program of work that will touch every department over time? How are you managing to roll that out?
So are you referring to the health checks, Jean?
Yes, sorry, health checks, yeah.
Yeah, no, well, we haven't actually started. So they're a kind of April initiative, and the initial plan is that staff will be able to self-book into the occupational health system. But the kind of mid to longer term view is that we will do more targeted approaches, get the actual checks into the workplace, so that those areas where we do have data that suggests that staff may be more at risk, there'll be a more targeted approach. But to kind of kick it off and roll it out, we're taking more of a kind of self-booking, self-referral approach.
Oh, right. Okay, thank you.
Thanks, Jean. Jackie.
Yeah, thank you, Paul. Excellent presentation as well. I have a comment and a question. So my comment is, obviously we are looking to reduce our sickness absence, but I have a very real concern. Having been in this health field for over 20 years, my concern is the size of our workforce function. It's been severely depleted over the years.
You've gone on to mute, Jackie. We can't hear.
Sorry, did you hear any
The
of that?
size of the workforce function was where you cut off.
All right, so the workforce function is severely depleted from where it was about 20 years ago. I feel it on the ground in terms of availability, and we're talking about supporting managers so they can follow these policies, implement these policies, but also workforce are key in terms of advising our staff as well. So I think for me, my comment is that I am genuinely worried if you compare our workforce function to other health boards, it is woefully small. I just want to make that comment. My question is to Paul, and he might not be able to answer this, but I'm very well aware of the wellbeing work and the resilience work, which I think is excellent. And I'm just wondering, are you seeing our staff, while they are not off sick, while they are still in work, are you seeing them access wellbeing so they get support to stay in work? Or is it more that, so the wellbeing support is there, they've already gone off sick, they're struggling, and they've been advised to go to wellbeing?
So I can answer that question, Jackie. And if I just have a look at the slide that had the relevant data on, it states, no, it doesn't. So I think the stats are just over half of the referrals we get are people in work. So we're clearly supporting a lot of staff who are in work and struggling and are seeking support whilst they're in work to remain in work. And then I think just under half are absentees who are obviously seeking support to manage their health to get back to work. So yeah, definitely in that kind of early intervention presentee space, which is where we want to be.
Thank you. Thank you, Paul. That is very good to hear. Can we just go back on the size of the workforce function question? Is there any evidence that we are a lot smaller in size than others? It may be something we take outside and but yeah, okay. Well, I think I'd just like to understand that, and if so, what the mitigations are, because clearly, given the previous item in the before lunch, we don't have a lot of spare cash around to expand teams significantly, but at the same time, we need the right size of teams to do what we need to do. Okay, Nuria.
I know that Paul and Sarah have heard me say this before, and I probably sound a bit like a broken record, but there's two things for me. One is to commend the work that Paul and his team does. You know, it's exemplar and it is really outstanding. So thank you, Paul, for all the hard work. The second is around data, and it's around data around sicknesses. And I know, Sarah, you've heard me say this again and again and again. sickness absence follows seasonal patterns, so you need to compare long-term periods rather than month-by-month basis. And I think we need to get those trends and that bigger picture. In terms of the work on resilience, I think that this fits into the conversation that we had earlier around the annual plans. And there's so much more than what Paul and his team does in terms of realistic expectations, the self-care and well-being of our staff, emotional intelligence we've touched about, support, to be in a supportive culture, that sense of purpose that we want of our staff. And I think there is a real opportunity now to step up our efforts around what resilience actually looks like in terms of our Swansea Bay and our new directional travel with our annual plan.
Thank you, Nuria. Really good point about data, seasonal trends. I mean, it's something that we, I would like that not to get lost, because we do need to be aware of what we're looking at and measuring. Sarah?
Yeah, so one of the things we're working on and currently trialling within Nice Port Talbot with our maternity services, given the challenges there, is interactive live workforce dashboard. I haven't yet come to present that award committee, so if this is hot off the press in terms of that, I'm sure a number of independent members will be pleased to hear about that. So we're trialling that in a space that we really need it right now, which will allow us to really shape something that works really effectively to help us with the point that Nuria has raised.
Fantastic. Thank you very much indeed. Great, really good discussion. A very welcome report. Thank you very much. I'm not seeing any more hands, so I am going to move on. This is a report for noting rather than any agreement, but very helpful. We have no population health and partnerships. There was no meeting in between these two boards, but so we now move on to part 6, governance. Item 6.1 is to receive the key issues report from Audit Committee, which is over to you, Nuria.
And the report is there for noting, and the latest meeting, which precedes the minutes that you have in front of you, took place in March. We discussed many of the highlights in the report at the previous board meeting, and we have just discussed the BAF and the risk register, both items of today's agenda. So I would just like to alert you that we now have a deadline for the submission of accounts. It's been set as the 15th of July, and provide assurance that a meeting with members of the Performance and Finance Committee to discuss the analytical review where we look at spending trends and compare with previous years will be arranged in due course. I would also like to alert the board that from the 1st of August to the 21st to the 30th of November, a number of losses and special payments stood at £645,000. And I would also like to alert the board that at our latest committee meeting, we received the county fraud investigation into impersonification of agency staff. That's all from me, Emma. Happy to take any questions.
Thank you very much. I've now got myself.
I did a very fast tour.
No, that was helpful. Does anybody have any questions for Nuria? No. Okay, so we'll move on to the key issues report for Mental Health Legislation Committee. Steve?
Yeah, thank you. So the report is there. A couple of things to draw out. Under the mental health measure, CAMHS is doing much better than it has done in the past. It's always been a problem area. It's still a challenge, but the trajectory is definitely in the right direction. And as the report says, this has been acknowledged by Welsh Government, who have congratulated the team and thanked us. There remains a challenge with getting care and treatment plans organised properly. This is something that's done in partnership with local authority partners, and we're trying to work together with them to get those statistics up to a better place. Under the Mental Capacity Act monitoring report, I think I said at the last meeting that a new structure has been put in place, and the new team has moved to the primary care service group. A new lead will be appointed. I think probably should have been appointed by now. They were due to start a couple of weeks ago, and that whole process looks to be in a much better place than it was. So the committee walked away from the last meeting with a metaphorical smile on its face as a consequence of the improvements that have been made under the Mental Health Act monitoring. Sorry, still under the Mental Capacity Act. The one issue that we have that I've reported to you in the past is the low number of best interest assessors. It's getting better. We now have 3, plus we can bring in independents on a case by case basis, but there's a lack of finance around that, and so that remains a risk in the register of 20, but a lot of focus on that. And the only other thing is I sometimes report on adolescents being placed on Ward F, which is considered inappropriate. It has not happened in the last, I think, 2 quarters that we've heard reports on. So that's something is happening to prevent those individuals being inappropriately placed on that adult mental health ward. So that's all I wanted to say. Thank you.
Thank you, Steve. I'm going to bring Larissa in. As we answer that, can anyone provide shed any light on the fact that we're avoiding because that is really good. It was a big
so about, I think it was Christmas time, they set up a sanctuary service. So Welsh Government funded a extra provision. It's provided by a local third sector organisation. I can't remember which one it is, but I think that will be having some impact. The mental health team, the reason I had my hand up is I think we need to probably get them back to do a bit of a kind of 12-month year-on review on CAMHS, because I think they've done an absolutely fantastic job in terms of taking what was a complicated, disorganized service and actually turning it around. So and that sanctuary service is a component that will be helping. But they've done a lot of really good stuff in the service to get things moving ahead. So they're now achieving targets. They're doing things that they didn't do before. So and so it would be really helpful, because I don't think it's getting a very much of a hearing. I know they did some stuff for the Children's Commission as part of Mental Health Week a few weeks ago, and did a really kind of good presentation to that. So it might be worth us getting a bit more of a focus on it, because I think they've done really well.
That's great. That's really good. I think it would be good to get that in some form. We'll take it offline as to where it goes, but I think that would be a good thing to do. Great, thank you, Steve. I'm not seeing any more hands, so I'm going to move on to the report on corporate governance issues to Hazel.
Thank you, Chair. So this is part of a routine report we bring to board, which sets out the in-committee discussions we've had in the previous board, Welsh Health Circulars, Business Cycle and the Commons Seal Register. It also, for this report, includes a board effectiveness action plan for the actions assigned for board oversight and scrutiny. The other parts of the action plan are now being reviewed by the subcommittees of the board, and they'll be reported back to board on an ongoing basis. The action plan was developed following the external review of board effectiveness, and also includes actions from the structured assessment review as well. It's there for noting, but happy to take questions.
Thank you, Hazel. Do we have any questions? And my brief suggests that I ask us to identify any specific areas where members feel that further assurance is required in relation to the board effectiveness action plan. Or do we think that adequately covers the?
I think it's adequately covered.
We think it does. Excellent. Okay. Thank you all very much. Thank you, Hazel. That's great. And now we have 6.4, which is a report on the establishment of the NHS Wales Joint Committee. We are being asked to adopt the amendments to our standing orders to reflect this. So I'll hand over to you, Hazel.
Yeah, so this report basically sets out the reasons for the review that were undertaken, and as a result of the review, the joint commissioning committee directions came into force on the 7th of February, and the joint commissioning committee will take effect from the 1st of April. As a result of which of that new organisation, we now need to formally adopt a number of documents. The model standing orders agree to that, standing orders for the NHS Wales Joint Commissioning Committee, scheme of delegation and reservation of powers, and also the standing financial instructions as well for the joint committee.
Thank you, Hazel. Do we have any comments? Steve, yes, I thought you wanted to say something. Thank you.
Yeah, thank you, Chair. So obviously we will adopt all these instruments because the joint committee needs to get started next week. So I'm not suggesting we don't. One caveat I have is the way that the audit and risk structure within the joint committee, and it was also the case in the old WISC, has been set out. That what happens is that the host body, which is Cwmtaf Morgannwg Health Board, provides the audit and risk cover for the joint for the joint committee. And while I think it's appropriate that they should provide, they should have their audit and risk committee should oversee the aspects of the joint committee's activity which relate specifically to Cwmtaf. There's actually a lot more than that going through this organisation. It's about 1.4 billion. It will be about 1.4 billion of public money, a lot of it of which comes from us and comes to us. And I believe that the audit and risk issues should be dealt with within the new organisation by a specific committee of the new organisation. And rather than being looked at by the Cwmtaf Audit and Risk Committee, who, you know, with the best will in the world, they're not close enough to the issues. If we were hosting them, for example, our people wouldn't be close enough to the issues, in my view, to fulfill that function. So my advice to the new organisation, and I think it will be asked because it's been suggested that because I was an IM on WISC that I should support the transition for the first quarter or so. My advice will be to change that structure if we can, and to create a specific JCC Audit and Risk Committee, which in my view could easily be populated by the chairs of the Audit and Risk Committees of each of the constituent health boards, as they do with the Quality and Safety Committee of that organisation. So, you know, Richard will be sitting on the new JCC if he agrees, and if we ask him over time. I think this is something that ought to be changed. And I know the outgoing WISC leadership certainly agree with that view. So they'll be saying the same things to their successors. So just a note, we obviously will adopt all these documents at this meeting.
Thank you, Steve. I think that sounds extremely sensible, and I think it's important that we note that. I'd be interested in Nuria's view if she has one, but in the meantime, I'll bring Jean in.
Yeah, I think Steve's point is very salient, Emma, and I have real concerns that unless it's acted upon, there is the propensity for lack of transparency across the whole of the health boards, and there's the potential for conflict of interest further down the line. So I think someone should listen to what he is saying and his experience be brought forward in this matter, notwithstanding that we would adopt standing issues.
Thank you, Jean. Nuria?
I think Steve's points are really well made, and so are Jean's. There is an opportunity to look at this when we have the meeting of the All Wales Audit Committee Chairs Group, which I'm currently chairing. So it'll be on our agenda, and I can feed back what Audit Committee chairs think, and maybe there'll be a mechanism to do that through your involvement with WISC, Steve. So I think that there is potential for us to look at this more closely in the coming months.
Thank you both, all in fact. Okay, I'm not seeing any further hands, so I'm going to ask the board to adopt the amendments to the model standing orders and reservation and delegation of powers for local health boards, and yeah, as in the paper, I think I'll say, and also to adopt the standing financial instructions for NHS Wales. So, i.e., make the changes required to facilitate the formation of the joint commissioning committee. I'm seeing nods, so I'm going to take that as approval. Excellent. Item 6.5, receive the summary reports from the health board's advisory groups. Hazel.
Yep, so this report sets out that we have 3 advisory groups, one of which hasn't met since the last time the board met. It had to cancel the meeting on the 14th of March. In terms of the Health Board Partnership Forum, they covered issues such as industrial action, maternity and neonatal services, continuous flow, integrated medium-term plan, the people strategy, occupational health and staff wellbeing service, Tata Steel workforce metrics. So I think it's fair to say that that meeting is going from strength to strength. And then in terms of the health professionals forum, they are looking at having a reset in terms of looking at the work programme and how to bring issues of relevance going forward. At the last meeting, they looked at the development of the annual plan and pan cluster plans and the board business update as well. That's all I was going to say, Chair, and happy to take any questions. Also, I can see Andy's here, and I didn't know if he wanted to come in on anything.
Thanks, Hazel. I will go. Yeah, I will see. Yeah, Andy would like to come in. That's great. Thank you, Andy.
Yeah, I guess I just want to bring to our record, really, our thanks from Jude and I in particular to the chair and executive lead of the Health Professions Forum in Betsy Cadwallader University Health Board. They were kind enough to give us some time to talk through how their forum is functioning, but also they and their membership then allowed us to be able to join one of their meetings. And it's really given us some really good food for thought in terms of guiding us towards developing our action plan to both enhance our membership, but also the role and function of the HPF and how it's viewed and used within the health board going forward. So hope to be able to bring some of that into our future board meetings or development sessions.
Excellent. That's really good to hear. Great, really good. Thank you, Andy. Rena.
Apologies if I'm not up to date on this, Hazel, but have we actually managed to appoint a chair and a vice chair for the stakeholder reference group? Because I know there was concern about how that was functioning, and I do think it's a really important group for us to take, if you like, things to and to get views from. So I just wondered if you could update us.
Yeah, you're right, Trina. It is a really important group, and they were looking at resetting that. My understanding is that they're still in the process of doing that, but I'll gain an update and let you know.
If you recall, we did approve a small stipend to the chair, didn't we? Which hopefully will make it easier to a more attractive role for somebody from on a voluntary basis. But I think that's right. So I think, can we bring that back to the next board, Hazel? Because it is, yes, as it says, it's an important group and it's struggled for a bit, hasn't it?
Yes.
Excellent. Good. Okay. Thank you all very much. So we've now reached the part of any other business. Does anybody have any other business? No, in which case I thank you all for your contributions and papers, and to those who are listening. And I think we've come to the end of this board meeting. If board members could stay on for a brief review of effectiveness, I'd be grateful.